One. Ma'am, please start. We are live.
Namaskar and good evening, everyone. A very warm welcome for today's webinar on Oncology as on today, Essence of ESMO and WCLC 2022. And with immense pleasure, I would like to invite Dr. Naresh Somani, who is MD, DM Director, Oncology and HOD Medical Oncology, HCG Cancer Center in Somani Hospital, Jaipur, for the welcome and introductory note and to set the ball rolling. Over to you, sir.
Thanks, Ms. Ekta. Good evening and welcome all of you, all delegates, faculties, participants. As you must be witnessing that over the last 3 years, once the COVID started, we had fortunately or unfortunately this series of the webinars across the country and the globe. And we developed gradually the two things, that is the post-ESCO, best of ESCO, that is the best of clinical oncology symposium we developed based on the conferences held in the month of the May and June every year across the globe. And then we chosen the essence of the oncology as on today based on the ESMO, WCLC, and anything else which is important during this period of last 2 to 3 months. So we have done a blend of the mixture of the based on these conferences as well as what the recent otherwise has come in the treatment breakthrough or the standard of the care, and mixing these all, we have tried to develop and design our program. And all my heads of the scientific committee like Dr. Vijay Patil, Dr. Vikas Talreja, Dr. T.P. Shau and others, they have done the immense job to support this meeting and infuse a lot of their time, expertise, their mind to develop and design the programs, which I believe should be of some importance and some relevance and useful for all of us for the practice changing and to make the things clear that what is the standard of care as on today at this point of the time. So without taking much of time, I will be welcoming all of you with a thanks note and hand over to the chairperson. Thank you.
Thank you, Dr. Somani. So I'm Dr. Pawan Agrawal from Jaipur. I'm friend of Dr. Somani. And Dr. Somani, thank you again for giving me the opportunity to conduct this session. And of course, your word is very wise because I have just seen that all three topics chosen in the head and neck carcinoma is beyond of today. So of course, I expect all our speaker will do the justice and make some things to future changing practices in our future coming. So behalf of my co-chairperson, Dr. D.P. Singh, I would like to invite the first speaker, Dr. Vijay Agrawal, who is a leader and senior consultant medical oncologist hematology, Esther RV College, Bangalore, and Esther CMI, Bangalore. And he will be speak on high dimensional immunophenotypic of immunotherapy response in head and neck cancer. So Dr. Vijay Agrawal, you have a 7 to 8 minute time. Please stick on time. And Dr. Ekta, please make the screen share for Vijay Agrawal.
Sure, sir.
Thank you very much. I'll share my screen. Sorry. Thank you, Dr. Pawan, and thank you, Dr. Naresh, for this opportunity to talk on a very interesting topic. And they would like to say the future is here, and it almost seems like, because when I got this topic, it took me a good while to try to understand this myself as to what we're trying to discuss and what was presented. A lot of this is pure science, basic science, but it's all molecular studies that I think it does give a flavor of what the future is to come in the next few years. This talk was done by Professor Ken O'Brien in ESMO in Paris earlier this month, looking at high dimensional immunotherapy response to head and neck cancer. And a lot of this talk was based on the basic biology of the tumor, and what they meant by a high dimensional immunophenotyping is basically evaluation of cellular components of the immune system using what they call as a single cell spatial phenotyping. And what they essentially meant is that today you could look at a tumor specimen. Gone are the days of talking about histopath evaluation, IHCs, looking at individual markers. What they could do is they could extract individual cells, count those cells, and analyze those cells. And when we're looking at a tumor, you're talking about a lot of cells. In the sense, you have tumor cells, you have immune cells, you have fibroblasts, you have vascular cells, you have the stroma, and even in the immune cells, you have B cells, T cells, CD4, CD20, and all of these things. And they could extract each and every individual cells. And of those individual cells, look at mutational analysis in the chromosome, look at gene expression in the microRNA, as well as using immunofluorescent flow cytometry or high throughput flow cytometry, look at receptors expressed on the cell surface. And they could do that on individual cells. And that is essentially what they were talking about, to see whether those analyses can then subsequently help us identify which tumors are likely to respond to immunotherapy versus those who are not. Clearly, immunotherapy is here to stay. With all the therapy in our practice. In our practice, it started off with melanoma, but now there are over 30 different types of tumors where immunotherapy has become the mainstay of treatment. And going forward, I think it will continue to be so. But when we're looking at tumor microenvironment, and I think a lot of talks have been done on looking at the tumor microenvironment in the blood, but the actual tumor microenvironment is in the tissue and not so much in the blood. So evaluation of this tissue is still the mainstay of our trying to understand how the immune cells interact with the tumor cells. Head and neck cancers, we all know that head and neck cancer is highly immunogenic. In our country, at least, the vast majority of the head and neck cancers are oral or oropharyngeal, the others making a small part of it. Now, on the right is basically a cross-section of a tonsil. A histopath evaluation looks completely differently. Now, in this, you can see varieties of colors, and they are basically each and every single cell that has got varied expressions on the cell surface giving the color. So you can look at the red ones being CD8, which is predominantly on the upper right here. The pan-CK is basically your squamous epithelium, which kind of borders it. The pink ones are your PD1, and your white ones are your PDL1. When you look down here, you can see very few immune cells. So most of the immune cells are concentrated on the top. The green bit is the normal tonsil. So you can get such varied expression in a single tumor, and that is what they were trying to kind of elicit. Now, they used a high throughput multiplex gene expression technique called the nanostring modular cancer panel. Now, this basically takes the microRNA of a single cell, which is a tumor cell, okay, and looks at about over 770 genes to look at differential expression of certain proteins belonging to various canonical pathways, such as your immune cell profiling, your checkpoint markers, resulting in IO drug targets, immune activation, cell death using apoptosis, and so forth. And this is kind of the map they came up with as differential expression of proteins compared to the normal. So tumor cell versus the normal cell. Now, when you start looking at each and every individual markers, there's certain markers that I would like to highlight, particularly the VISTA. VISTA, we know, is a checkpoint marker, which is associated with resistance to immunotherapy, because expression of VISTA bypasses the PD-L1 expression, because both of them tend to be checkpoint markers. Now, in a high tumor microenvironment, VISTA expression in other tumors is certainly associated with poor prognosis. So low VISTA expression essentially means that patients are likely to do better as opposed to high VISTA expressions. And a similar outcome was noticed with other markers such as CD127 and CD44. So clearly, we can start evaluating individual markers using tissue microarrays, high throughput tissue microarray techniques. Now, they went further to look at what they called as ultra deep immunoprofiling. Now, what do we mean by ultra deep immunoprofiling? Basically, this is your single cell spatial phenotyping. What I mean by that is that they look at each and every cell. They look at the cell surface expression or microRNA expression of those cells, and also its spatial orientation to other cells. So this was a head and neck cancer patient of a keynote 6669 study. 669, it was an oral tumor. This patient went on to receive pembrolizumab, an IDO1 inhibitor, epacadostat. And in this patient, there was a partial response seen with pembrolizumab with a PFS of 14 months. Now, when we look at this particular tissue, you can see that this is your normal tonsil. So there are various marker expressions. So these tend to be your B cell and the T cell expressed. And the tumors are kind of concentrated on the top here as well as the bottom here. And when we start looking at individual markers, we see more CD4 and CD8 expression on the top as opposed to the bottom. And what this UMAP on the right essentially shows the temporal relation of each and every cell. So you can literally count each and every cell. And what I mean by that is I'm just going to take you through this, because this is the main slide of my talk. This is a cross section of the tonsil that we were talking about in the earlier study. Now this is the UMAP of looking at each and every cell. So the number of cells they calculated was about 8,35,823 cells. So they extracted each and every cells. And if you look at this pie chart here, okay, and obviously the legend is here. So the 27% was the tumor cells, 18% was your vascular cells, then 11% was your B cells, and 13% was your 13 and 8% were your T cells. So these were the majority of the cells in that particular tumor. On your right is your cluster dendrogram showing the heat signature. So on the bottom here, you have the various cell types that were identified. That's on your x-axis. On your y, you have various markers that are expressed. And you can look at it that the heterogeneity is so much that for every different cell, there are different markers that are expressed. The blue being the coldest and the red being the hottest. And I'm not going to go into the details of that. But what I'm trying to elucidate here is that you have significant heterogeneity within the same tumor in between cells of those tumors. Now, when you look at the bottom there, you have a longitudinal section of the tonsillar tumor. And this, what they did was they divided them into obviously the normal tonsil, which is your red, and 4 different tumors from 4 different sections. So you have a tumor 1, tumor 2, tumor 3, and tumor 4. And when you start looking at the cell makeup of each and every one of them, you see that they are completely different. Your tumor cell 4 is predominantly CD8 and macrophages. And when you look at your tumor 1, that is predominantly tumor, there is very little immune infiltrates in them. So it is but obvious that different areas of the same tumor are going to respond differently to the immunotherapy that is given, depending upon the immune expression or the immune concentration that are present in those areas of the tumor. And that is why it is difficult, given the tumor heterogeneity, to get a complete response all across the board. And this may go to a significant extent in trying to understand why we get response between the areas which we can target to overcome resistance. But as you can see that in a normal tonsillar area, which is the green bit, you have predominantly CD4 cells. But when you start looking at the tumoral areas, you see more vasculature and tumor cells. And if you look at the top bit here, the orange bit, you've seen the CN5, which is your more immune infiltrated cells. So my hypothesis would be that the bits on the top here, which are more immune infiltrated, are likely to respond to immunotherapy better than the bits at the bottom here, where it's predominantly tumor with very little immune infiltrates. And we saw that in the bar chart as well, where your tumor 4, which is this, had more immune infiltrates, and where tumor 3 had very little immune infiltrates in them. So this is my last study looking at the same differential heterogeneity. Basically, this was done looking at a 103 plex kit, looking at 103 odd markers to look at how various cells. So you have your CD8 cells, you have your macrophages, M1, M2, and the tumor cells. Again, this is a cluster dendrogram, and you could see the four tumor types, tumor type 1, 2, 3, and 4, along with the normal tonsil, on the extreme right, along with the normal squamous epithelium. as to how varied they are in terms of the markers that are kind of expressed. And when you look at staining with G6PD, you can see that the tumor area 3 has got very strong G6PD staining, means they are more metabolically active. And BAC is an apoptotic marker or immunotherapy marker. And when you see the BAC expression is more on the tumor 1, 2, and 4, there's more immunological phenomena going on there, thereby saying that because of such differential expression, maybe tumor 1, 2, and 4 are more likely to respond to treatment as opposed to the tumor 3. So essentially, going forward, these techniques are going to give us some significant insights on the tumor biology as well as the intratumoral heterogeneity, and possibly reveal mechanisms of why tumors respond to treatment or they develop resistance or part of the tumor response to treatment for an next period of time where the other bits then start to progress. That is it from me. Thank you.
Please, thank you.
Thank you.
Thank
you,
you,
Dr.
Dr.
Vijay. Now we move on second.
Okay,
Rob
Pawan, continue, please.
I think Dr. Manisha Singh has also joined. We welcome her also.
Yeah, good evening, Dr. Samani. Thanks for the invite. I'm here. I'm very much here. And I'm enjoying the talk.
Please.
So now we move on to the second topic on this session, and that is the evaluation of RNA damage response network as a predictor of nivolumab efficacy against head and neck squamous cell cancer. And it will be presented by Dr. Vikas Talreja. He is a senior consultant medical oncologist, Regency Hospital, Kanpur. So I invite Dr. Vikas, please. And Dr. Vikas, please stick on time. We are already 5-7 minutes late. Thank you.
Thank you for the kind introduction. I will not be bothering much more of our time right now. I know the value of the time right now. And I believe this is a very important topic that has been carefully selected by Dr. Somani and the whole scientific committee. I personally looked after this topic as a very important future potential biomarker for the predictor of the nivolumab efficacy, which is very important in our daily routine practice. So it was presented by the Yale group in the ESMO 2022. It was a very important discussion for us. The evaluation of the DNA damage response as a predictor for nivolumab efficacy. So the study was very simple, that it was a group of pathologists who looked after the DNA mismatch repair genes, which were, can I request the team to please share the slides on my behalf? And move to the third slide. Yes, so perfectly fine. So what they did was they looked at the peripheral blood mononuclear cells initially, which had a DDR related parameters and a higher levels of oxidative stress, a known endogenous DNA damage matters as compared to the healthy individuals. And they found, put it up the hypothesis that those with the DDR signals may predict therapeutic benefit ratios in the head and neck squamous cell carcinomas. Next slide, please. So the methods was simple: the oxidative stress, the DDR associated parameters, which includes the endogenous DNA damage and the basal DNA repair genes known for the nuclear excision repair and the double strand break repairs, were evaluated, and they were treated in a phase 2 concurrently going trials for the nivolumab, and there was 26 healthy controls. And the peripheral blood mononuclear cells were evaluated at baseline, 4 weeks of nivolumab, and at progression. Next slide, please. So the method included the endogenous DNA damage, which includes a CNA, a single and a double stranded breaks, the alkaline comet assays. The double stranded breaks were assessed by the confocal microscopy. Oxidative stress was assessed by, again, the glutathione ratios, the abasic sites, that includes the AP sites, and early stage DNA lesions, which is as a result of the oxidative stress, was detected by a DNA quantification kit and a nuclear excision read, which was an in vivo ex vivo treatment with the cisplatin by a southern blot analysis, a double strand break by a confocal microscopy, and apoptosis rate by a apoptosis kit. So next slide, please. The peripheral blood mononuclear cells from the head neck squamous cell carcinoma showed a baseline high levels of endogenous DNA damage, which includes the single stranded breaks and the double stranded breaks compared with the healthy controls. After 4 weeks of the treatment with nivolumab, it did not affect the levels of the DNA damage. The peripheral blood from the head neck squamous cell carcinomas at baseline exhibited a higher level of oxidative stress, as you could see from the corresponding graphs, and a basic size as compared with the healthy controls. The DDR-associated pathways, next slide please, at the baselines, also following the ex vivo treatment with the cisplatin peripheral blood mononuclear cells, showed a reduced NER and increased double-stranded braid repair capacity. The higher cisplatin doses are required to trigger the apoptosis in peripheral blood mononuclear cells as compared to the healthy controls, indicating that the patients are characterized by a lower apoptosis rate. And if we look at the single strand breaks and the double stranded breaks and the response to nivolumab, the lower levels of the DNA damage at baselines were higher likelihood of response to the nivolumab, improving the clinical benefit rate and longer overall survival, as you could see from those graphs. Also, the lower levels of the DNA damage at the baseline were associated with higher likelihood of response to nivolumab, improved clinical benefit, and longer OS. Next slide, please. The lower levels of oxidative stress at baseline were associated with higher likelihood of response, improved clinical benefit rate, and prolonged overall survival. If we look at the nuclear excision repair capacity, the individual reduced nuclear excision repair capacity, that is increased cisplatin-induced monoadducts at baseline, is associated with the higher likelihood for response and improved clinical benefit rate and higher overall survival. And if we look at the double-stranded break repair capacity, the reduced double-stranded repair capacity is associated with a better clinical response, improved clinical benefit rate, and a higher OS. Also, the higher cisplatin dose are required to trigger the apoptosis in peripheral blood mononuclear cells from the responders compared to non-responders, indicating that the responders to nivolumab are characterized by a lower apoptosis rate. So a lot to take out from it, that yes, these are newer potential biomarkers for the nivolumab to be given in the head neck squamous cell carcinomas. Some of the valid promising hypothesis generating and definitely clinical trial biomarkers are the reduced endogenous DNA damage, the oxidative stress, the DNA repair capacity, and apoptosis rates in the peripheral blood mononuclear cells of patients with head neck squamous cell carcinomas with a better response to nivolumab therapy. Definitely a larger phase 3 trial with a broader cohort and a prospective way of doing it will be a much better way of doing it. That concludes my presentation, and over to the organizers for a lovely crafted agenda and a beautiful conference so far.
Thank you, Dr. Vikas. Although you have said everything is very tempting and very interesting, but I think the research area of the evaluation of response rate in India is not, I think it's not available. So we have to go far ahead to develop all this facility which you are talking in India, and particularly validated also. So otherwise, it's a very good idea what you are saying. And now we move on the third topic, that is a molecular target in salivary glands cancer, the comprehensive genomic analysis of 1,666 cases. And our speaker is Dr. Rakesh Meenati. He is a consultant medical oncologist, Bhavakaram Hospital, Hyderabad. So over to Dr. Rakesh Meenati.
Thank you, sir. Good evening to all. Thank you, organizers, for this wonderful opportunity. So I'm going to present a very interesting abstract. This is the 5285 molecular targets in salivary gland cancers, a comprehensive genomic analysis of 1,666 cases. So this is the disclosures from the presenters. So coming to the background of basically salivary gland cancers, these are rare but very diverse group of cancers in the head and neck subdomain. There are wide varieties of histological subtypes and genomic alterations, and it could range anywhere from a very benign tumor, a low-grade tumor that requires only surgery and no adjuvant treatment, to high-grade cancers and tumors with high-risk features which require subsequent adjuvant radiation therapy as well. When it comes to metastatic disease or advanced disease which are not potentially curable, and these patients can be observed or considered for systemic or local therapies based upon the tumor and patient characteristics. And when we look at advanced disease that potentially looking at systemic therapy as an option, I think most of the solid tumors are moving in the direction of precision medicine, looking at the next generation sequencing and trying to identify a potential target. And this was the main objective of
Support team, please take care. Dr. Pinati is not audible to everyone.
Yes, sir, we are connecting, sir.
I think the power is suddenly power off from Dr. Pinati's side. Now he is getting rejoining. Meanwhile, okay, Dr. Pinati has rejoined.
sorry, I got disconnected. Can I start again?
Yeah, sure, Doctor.
Sorry for that. And can the organizers share my slides, please? So should I start from the slide?
Yeah.
One?
Yeah.
Yeah, thank you. To present the abstract 5285, which is basically the molecular targets in salivary gland cancers, a very comprehensive genomic analysis of the 1,660 cases. Next slide, please. So these are the disclosures from the presenters. Next slide. So salivary gland cancers are a rare tumors of the head and neck subtype, and these include a wide group of malignant neoplasms and variety of ecological subtypes and genomic alterations. And they can range anywhere from a benign tumor or low-grade tumor that requires only surgery and no adjuvant treatment to high-grade cancers, which are usually treated with surgery followed by adjuvant radiation. And those salivary gland cancers which are metastatic and those are not amenable for local treatments can be subjected to systemic treatments based upon the tumor and patient characteristics. And while we are considering for systemic treatments, I think in the most of the solid tumors, the trend is to try to identify a genomic sequencing analysis and try to identify targetable mutation. Thereby, we can provide a much more scientific way of treating things which are with a lot less side effects. And this was the objective of this study. Next slide, please. So this was a retrospective observation cohort study that included patients with the advanced salivary gland cancers. And this is basically Foundation 1 database. And very rare subtypes of frequency less than 20 types, 20 were actually censored. Coming to the molecular techniques, they have employed the DNA extracted from the tissues from the advanced salivary gland cancers. They subjected to comprehensive genomic profiling. Foundation 1 CDX assay was used, and basically genomic bait set of 324 genes were analyzed for substitutions, insertions, copy number alterations, and rearrangements. Apart from that, they also tried to identify the tumor mutation burden as well as the PD-L1 expression, which is determined by the DACO 22C3 platform. Next slide, please. So in overall, this is the distribution of the various histological subtypes. The most common type is the adenoid cystic carcinoma, followed by the salivary ductal carcinoma. The rarest of them was the basaloid carcinoma. Next slide, please. So this is the summary of the clinically relevant genomic alterations in the salivary gland cancers. If you look at the tumor mutation burden and PD-L1, we can see that the highest percentage was seen in the mucoepidermal carcinoma, 16.9, as well as in the high-grade carcinomas at around 18.3%. And basically, the PD-L1 high was also seen in the similar subtypes at around 4.2 and 6.3% and 8.9%.
Apart from that, the most common genomic alterations was seen in the cyclin-dependent kinase 2A and 2B, which was seen in nearly 52% in mucoepidermal carcinomas and around 32% in the myoepithelial carcinomas. Next slide, please. So these are some of the targetable genomic alterations in salivary gland cancers. We already discussed that tumor mutation burden was pretty high in those patients who were having basically high-grade carcinoma NOS and as well as the mucoepidermal carcinoma, 16.9% and 18.3%. Moving on to the FGFR mutations, it is around 11.8% in the pleomorphic adenoma, and also in the pleomorphic adenoma, there are high percentage of patients with the HER2 expression amplification at around 20% in the salivary ductal carcinoma as well as in the pleomorphic adenocarcinoma. More interestingly, the PIK3CA mutations were seen in nearly 1/3 of the patients in the salivary ductal carcinoma at around 32.6% and 1/5 of the patients in adenocarcinoma NOS. And we can see that other much more commoner subtypes like adenocystic carcinoma and mucoepidermal carcinoma are also seen around 9 to 15% of them also show the PIK3CA mutation. And the other rare mutations like BRAF, RET, and BRCA2 mutations are range from 3 to 5%. Next slide, please. So this is basically overall conclusion. This is a very large data set of this rarer salivary gland cancers. This provides the information that there are opportunities for immunotherapy as well as the precision targeted therapy in these cancers. The PIK3CA mutation was seen in nearly 1/3 of patients in salivary ductal carcinomas and high-grade NOS, basically 21.3%. One of the PIK3CA mutation that can be targetable with a drug, which is alpelisib, can be a consideration for these cancer patients. The ERBB2 amplifications, again, seen in nearly 20% in the pleomorphic adenoma and ductal cell carcinoma. Basically, the anti-HER2 therapies can be an option in these patients' management. Coming to the limitations of the study, it's a retrospective data set. It has its own confounding factors that can be associated with the retrospective data set. These are all percentage description of the mutations. There is no information regarding the treatment as well as the clinical outcomes and survival for these patients. However, it provides an opportunity for future directions. It provides an opportunity for hypothesis generating data that is out there, basically trying to find out a targetable mutation, try to match some amount of treatment with the targetable mutations and taking it forward in the future clinical trials. Next slide, please. So that will conclude very brief discussion of this abstract. Thank you for this opportunity. Thank you. And over to the organizers. Thank you very much.
Thank you, Dr. Rakesh. It's a really nice presentation of a very rare tumor of head and neck carcinoma and very elaborative information. So thanks everybody. Now our head and neck session has been over, although we are a little late. And I invite my next chairperson of next session is a breast cancer, and I invite Dr. Hemant Malhotra sir, who is the director and oncology services, Sri Ram Cancer Institute, as instituted in Mahatma Gandhi Hospital, Medical College in Jaipur. And I also invite co-chairperson Dr. Manish Chamal. He is a senior consultant HOD Radiation Oncology in HCG Hospital in Jaipur. And I also invite Dr. Sudhir Palsania as a consultant medical oncologist, Department of Medical Oncology, Shelby Hospital, Jaipur. So over to for next session to my co-chairperson. Thank you.
Thank you, Dr. Pavan. Am I audible and visible?
Yes, sir.
Yes, yes, sir. Yes, sir.
Thank you very much. So on behalf of my co-chairs, Dr. Manish and Dr. Sudhir, I'd like to thank the organizers, particularly Dr. Sumani, for this opportunity. And in my yardstick, the measurement of a good conference is that it should stick to time. And, I think we will try and do that and make this not only a good conference, but an excellent conference. So now we are in this session of breast cancer. And if I could just start the ball rolling, and then I would request Dr. Manish and Dr. Sudhir to take over. The first session is on triple-negative breast cancer and the role of checkpoint inhibitor, particularly atezolizumab in triple-negative breast cancer. And this is a Roche-sponsored session. I'm very happy to introduce the speaker to you, Dr. Anu Rajpurohit. Very proud to tell you that Anu is a student of SMS. I hope she learned a little bit from me also, and she's trained at the Tata Hospital. And over to you, Anu.
Thank you so
Sorry
much,
to
sir.
interrupt. Sorry to interrupt. Is there anybody in this conference or in country who has not learned from you somewhere or sometime? Is there anyone, sir?
So kind of you, Naresh. Thank you. I appreciate that. Thank you very much.
Thank you, Malhotra, sir, for the kind introduction. Thank you so much, sir, for giving me this opportunity. Shall I begin?
Yeah, please go ahead. We can hear you and see you. Just share your slides and go ahead.
Yes, sir. Is it visible, sir?
Yeah, we can see the first slide. Please go ahead.
Yes, sir. So today I'll be talking about the role of immunotherapy in triple negative breast cancer. As we all know that the breast cancer is the most frequent diagnosed cancer in women and ranked second amongst all the causes for cancer-related death in women. So now many researchers are being going on, providing the improving in the clinical outcome in the breast cancers. Now we also have screening, diagnostic and therapeutic strategy engaged in breast cancer management. However, poor prognosis in triple negative breast cancer and drug resistance presents major inhibition, which are also current challenges for containing the disease. So coming to the classification based on histology and molecular markers. So breast cancer can be divided into in situ carcinoma and the invasive carcinoma. Today we'll be talking about invasive carcinoma. Based on histology, there are multiple types: tubular, ductal, lobular, invasive lobular, infiltrating ductal, mucinous, medullary, and uncommon one, papillary. Based on molecular classification, we have luminal A, luminal B, HER2 enriched, and basal cell, basal-like carcinoma. So these are the histological slides. Now coming to the prevalence of the breast cancer based on histology. So most common being invasive ductal carcinoma, ranging between 65 to 80%, followed by invasive lobular carcinoma, followed by tubulolobular, then invasive cribriform carcinoma, medullary, and some of the mentioned carcinomas are the rare ones. So in basal, like we have ERPR negative, HER2 negative, means all the targets are negative. In HER2 positive, we have ERPR negative and HER2 positive. Normal basal like breast, like in which we see either ER is positive or negative with PR unknown and HER2 negative. Luminal is having ER positive or negative, similarly with PR, and the HER2 is negative or positive. Basal like and the HER2 positive are having high proliferation rate. The lowest one is the normal breast like. Now coming to the incidence of TNBC, TNBC accounts for the 10 to 20% of the breast cancer worldwide, but in Indian scenario, it is a bit high. It ranges between 27 to 34%. And half of them, they present in advanced and the metastatic stage. The minimum age of presentation is 22 years, the maximum 75 years. 60% of the patients are less than 50 years. So as we all know that TNBC like expression of ERPR and the HER2. Now coming to the common characteristics of TNBC tumors compared to other breast cancer tumors. So they are having more likely to have great histology, large tumors at the time of diagnosis, high mortality rates, more aggressive disease, and higher rates of distant recurrence. So it has significant unmet medical needs. Coming to clinical outlook for patients with TNBC, when we compare to other breast cancer, there is higher risk of spread outside the breast within first 5 years of diagnosis compared to other breast cancer. Mean time for distant recurrence is also lower. Decrease in 5-year survival with the standard therapy versus other breast cancer is also lower. Median survival for women with metastatic TNBC is less than 1 year, and amongst all patients almost all patients die from the disease despite having aggressive systemic chemotherapy options. So these are the survival rates based on the stage of the disease. As we can see, whether it is localized or advanced stage 4, clearly the TNBC has lower survival. And the likelihood of distant recurrence is high in TNBC patient. We can see the graph, the TNBC is constantly lower than the other breast cancers. So definitely we have a very high unmet clinical needs. OS is worse than in TNBC patient. Recurrence rate is also high. We don't have other option other than chemotherapy, and the disease being aggressive, heterogeneous disease that needs further segmentation into treatable subtypes. Now coming to the very characteristic feature of TNBC, that is T cell infiltration in TNBC compared to the breast cancer. You can clearly see that the TNBC has the highest T cell infiltration. So the high mutation rate of TNBC may produce tumor-specific antigens that induces immune response by which there is infiltration of T cells. So if we see if there's T cell infiltration in TNBC is associated with prognosis or not. So they've done some research. For each 10% increase in the level of stromal tumor infiltrating T cell, there is 19% reduction in the risk of death, 13 to 80% risk of distant recurrence, reduction in risk of recurrence or death by 14%. So PD-L1 expressed on TNBC can suppress the immune response, is therefore a potential therapeutic target. So the therapy which targets the PD-L1 or PD-1 pathway may therefore enhance the immune response. So this is showing the TCGA data that the higher PD-L1 mRNA expression in breast tissue specimen from the patient with TNBC compared to the non-TNBC. So this diagram is showing tumor microenvironment. It is showing how PD-L1 activation leads to deactivation of the T cells. So by targeting the PD-L1, we can actually promote the T cell activity and by killing the tumor cells. So what is the current management of TNBC? As we all know that if it is localized primary breast cancer, we have adjuvant chemotherapy after surgery or neoadjuvant chemotherapy before surgery. And then there are some options for the post-neoadjuvant chemotherapy also. But if we come to the metastatic TNBC, in first line, we have Taxanes and the platinum-based combination. If we talk about the second line, there are capecitabine, then again platinum-based combination, eribulin. If we talk about third line, then we have only eribulin and the best supportive care. So mostly we have seen that we have anthracycline, Taxanes, and platinums. And to choose between single agent or combination, we see some of the parameters, including performance status, risk of adverse events, prior chemotherapy regimens, disease burden, and patient preferences must be considered. So combination therapy is shown to have improved response, however, associated with more adverse events. So these are the survival outcomes with the recommended treatment regimen in metastatic triple-negative breast cancers. We can see the OS and PFS. So to summarize this, metastatic TNBC is currently incurable. The mainstay of treatment is chemotherapy, usually single agent therapy. Double agent can be used based on the certain parameters. Now coming to the role of immunotherapy in triple-negative breast cancer, this is the first trial, I am patient 130 trial. Coming to the design and the results, it was phase 3 Tecentriq study in metastatic triple-negative breast cancer. The key eligibility criteria were metastatic or inoperable locally advanced TNBC, no prior therapy for advanced TNBC, prior chemotherapy in curative setting were included, including Taxane, allowed if treatment-free interval is more than 1 year. ECOG PS was 0 to 1 and any PD-L1 status were included. So they further stratified based on the prior Taxane use, liver metastases are there or not, and PD-L1 status. They divided into 2 arms, Tecentriq plus Nab-Pac arm and the placebo plus Nab-Paclitaxel arm. The primary endpoints were the PFS and the OS in the intent to treat population and the PD-L1 positive population. Key secondary endpoints were the overall response rate, duration of the response, and the safety. So the choice of Nab-Paclitaxel, as we all know that it has a lesser risk of having hypersensitivity reaction. But if we see the overall data, there is no difference between using Nab-Pac or Paclitaxel. So we can combine with either Nab-Paclitaxel or Paclitaxel. So this is the study design. So they randomized 902 patients. They divided into two groups, Tecentriq plus Nepex, then the placebo plus Nepec arm. On study, there were 246 in arm 1 and 219 in arm 2. And they did survival follow-up in 182 patients in arm 1 and 166 patients in arm 2. So coming to the baseline characteristics, so they were generally balanced. The median age was 55. Almost all patients were female in placebo plus Nepec, 99 in Tecentriq plus Nepec arm. ECOG PS was 0 to 1. Prior use of adjuvant or neoadjuvant treatment was prior taxane or anthracyclines. The most common site of the metastasis was lung, followed by bone, liver, and brain. PD-L1 positivity was present in 41% in both the arms. Primary PFS analysis in intent to treat population, as we can see on our left, that the PFS is 5.5 months in placebo plus Nepec arm versus 7.2 months with hazard ratio of 0.08 in atezolizumab plus Nepec arm. 1.7 months significant median PFS benefit was observed with the addition of Tecentriq to Nepec arm. Based on PD-L1 status, we can clearly see that the effect was more in the patient who had PD-L1 positivity. The HR was 0.62 in PD-L1 positive patient versus 0.9 near to 1 in PD-L1 negative patients. So the effect of atezolizumab was more pronounced in the patient with PD-L1 positivity. Coming to the interim OS analysis, in intent to treat population, we can see both the curves are touching each other. So there was the median OS was 17.6 months in A, placebo plus Nepec arm, compared to 21.3 months in atezolizumab plus Nepec arm. Though it was not statistically significant at this first interim analysis, but it gave numerically it's 3.7 month median OS benefit. This is OS analysis by PD-L1 status. Similarly, as we have seen in PFS, here also the hazard ratio for PD-L1 positive patient, it is 0.062, and it is 1.02 in PD-L1 negative patients. In subgroup analysis based on liver metastasis, prior taxane use, PD-L1 status, we can see 3 of them are on the left of the center line. The PFS benefit was primarily seen in PD-L1 positivity. This is the response. Definitely the response was more in PD-L1 positive, like around 60% compared to the 43% in Nepec plus placebo arm. Now coming to the adverse event of special interest, we can see any grade of side effects were more or less same in both the arms, 57% in Tecentriq plus Nepec versus 42% in placebo plus Nepec arm. The hepatitis rate was balanced. All hypothyroidism events were only of grade 1-2. None led to treatment discontinuation, and pneumonitis was also infrequent. Common side effects were alopecia, fatigue, nausea, diarrhea, cytopenias, headache, neuropathy, and they were balanced in both the arms. Most common side effects. So the higher proportion of patients in the Tecentriq plus Nepec arm than in the placebo plus Nepec arm, clearly seen, 23% versus 18%, but the difference was not significant and all were manageable. Now coming to the updated efficacy and safety result from second interim analysis. In second interim analysis, we can see the OS, it is 42% versus 39% at 2 years. And the comparison of OS in PD-L1 positive and negative patient, we can see the effect was more in PD-L1 positive patients. This is updated safety analysis. They were well balanced and it can be used safely. So what are the key learning points and clinical implications? IMpatient 130 is the first phase 3 study to demonstrate the benefit of cancer immunotherapy in metastatic triple negative breast cancer. The benefit risk profile of Tecentriq plus Nepec supports a change in practice in first-line treatment of triple negative breast cancer. Then we have to see if the patient is PD-L1 positive, the benefit is certainly there, but not in PD-L1 negative patient. To summarize, as we all know that the high incidence of TNBC in India, TNBC is associated with high relapse rate and overall poor prognosis. Treatment options are also limited and mostly in form of conventional chemotherapy only. No new adverse events were reported. A clinical meaningful 25 months median OS benefit was observed with the addition of Tecentriq in the PD-L1 positive patients. IM patient 130 is the first trial, as we have seen, which showed the effect of the cancer immunotherapy in these patients. So based on the interim analysis, though US FDA has withdrawn the indication of the Tecentriq with NAPAC in TNBC indication, but if our patient has exhausted all the option and the patient has PD-L1 positivity, then definitely it is an option. Thank you. Thank you all.
Thank you, Dr. Anu, for this elaborated talk on TNBC management. And I thank the organizer for getting me involved in this wonderful conference. And the next session again is a pharma session sponsored by Eli Lilly. And the topic is, when cancer does not take a day off, then why should a CDK4/6 inhibitor? So I request the next speaker to please start with the talk.
Thank you, sir.
Sir, you can share your screen.
Ma'am, Dr. Krishna Prasad sir is joining. Just give me a 2 minutes, ma'am.
Till then, we can show that teasers would be. Of best questions.
Hi, ma'am. Good evening. Dr. Krishna Prasad sir will join in next 2 minutes. He's actually stuck up somewhere.
Okay. So, Pooja, can we show that teaser of best questions? So that attendees can type their questions, right?
Ma'am, Dr. Krishna Prasad sir has joined.
Okay. Yeah, good evening, sir.
Good evening.
Sir, you can share your screen.
Is it visible now?
Yes, sir, very much. You can go ahead, sir.
Let me know when I should start.
You can, sir.
Can start?
Yes, sir. Naresh Somani, sir, can sir start with his talk?
Let me know.
I think you should begin, sir.
Please start, sir.
Yeah. Thanks, Lily, for this opportunity. So this is just a clinical experience sharing of a patient on abemaciclib. So this basically is a 50-year-old lady who was postmenopausal. She presented with a right breast lump of 1 month duration. Biopsy showed it as IDC grade 2. It was T2N1M0, ER positive, PR negative, HER2 negative, and Ki67 was 70%. It was grade 2. So this patient actually underwent a BCS followed by standard chemotherapy, followed by radiation, and she was on letrozole. 1.5 years into letrozole, she presented with back pain. Clinical examination showed a right supraclavicular lymph node, and she had bony tenderness along the thoracic spine. PET scan showed extensive lytic sclerotic lesions involving the appendicular and the axial skeleton, right axillary and supraclavicular nodes, and some external iliac lymph nodes on the left, which we could not place exactly what it was due to. Supraclavicular lymph node biopsy showed IDC grade 3 this time, ER positive, PR and HER2 negative, and Ki67 was 45%. So basically a postmenopausal lady treated with adjuvant treatment for a stage 2 disease, now presenting with bone metastasis and lymph node mets. It is a grade 3 disease and PR is negative with a high Ki67. So when somebody presents with metastatic breast cancer, we look for characteristics which will tell us what could be the prognosis. There are some good prognostic factors, and then there are some factors which tell us that this patient is likely to do poorly. Now, those factors which suggest that patient will do poorly are a shorter time to recurrence from early stage. Generally, less than 2 years would suggest some form of endocrine resistance. Presence of liver and other visceral metastasis, a high-grade tumor like our patient, and patients who are PR negative. So progesterone receptor negative, a high-grade tumor, presence of visceral mets, especially liver mets, and a short time to recurrence. Now, these are the kind of patients who were put in the Monarch 2 study. So Monarch 2 study was designed for patients who are hormone receptor positive, HER2 negative advanced breast cancer, who are pre or perimenopausal, but predominantly they were postmenopausal.
and who had endocrine therapy resistance. So the definition of endocrine therapy resistance was patients who relapsed while on adjuvant therapy or within 12 months of completing adjuvant therapy, or patients who have progressed on first-line endocrine therapy. No chemotherapy should have been given for advanced breast cancer, and no more than one type of endocrine therapy. So they were randomized in 2:1 fashion to abemaciclib 150 mg 2 times a day on a continuous schedule with fulvestrant standard dosage compared to a placebo plus a fulvestrant treatment. The primary endpoint was a progression-free survival, multiple secondary endpoints, especially overall survival and safety, and some exploratory endpoints. Now, if you look at the progression-free survival, which was updated recently, you can see that compared to 2017, the PFS seems to be holding on. So the median PFS is around 16.5 months for abemaciclib plus fulvestrant, compared to around 9 months to fulvestrant alone with a hazard ratio of 0.5. So an excellent benefit with the combination of abemaciclib with fulvestrant. So if you look at the different subgroups, it is highlighted here that patients with the endocrine therapy resistance, PR negative, and visceral metastasis actually did better. If you look at the endocrine therapy resistance alone, primary resistance did come much better compared to patients with secondary resistance. What about the overall survival? So at an interim analysis, the overall survival compared to placebo was around 9 months better when you added abemaciclib to fulvestrant. So it improved from a median of 37 months to nearly 47 months. Even the overall survival, there was significant benefit for patients with visceral metastasis and patients with primary resistance. So what is this primary resistance? Primary resistance are those patients who relapse while on the first 2 years of adjuvant endocrine therapy or progress within the first 6 months of treatment for metastatic breast cancer. So these are primary resistant patients. So if you look at our patient, she progressed 1.5 years into adjuvant therapy. So this patient, really fitted into this Monarch 2 study, and she was started on abemaciclib 150 mg BD, and fulvestrant first 2-3 doses were 500 mg every 15 days. Then patient received monthly doses. Of course, she received zoledronic acid also. So the early experience is that, within 15-20 days, patients had significant improvement in terms of symptoms. The back pain settled down. We noticed a mild increase in creatinine and no other significant toxicity. So this increase in creatinine is quite interesting. We know that increased creatinine can generally mean a problem with the GFR, that is the glomerular filtration rate. But in abemaciclib, it is not the GFR which is abnormal. What happens is the tubular secretion of abemaciclib in, of creatinine actually is compromised, and hence the creatinine rises mildly. If you look at the Monarch 1 and 2 study, most of them, so you see that 98.5% of patients in Monarch 1 and 98.4% patients in Monarch 2 had an increase in serum creatinine. And how much was the increase? Median was 0.24 to 0.3. So this increase in serum creatinine has some implications. One of the consequences is many of our patients are on metformin for hyperglycemia, and metformin actually, the elimination of metformin is through the same pathway, and metformin seems to be working suddenly better when you start this drug. So what you have to be careful is look for a further increase or a progressive increase in serum creatinine, because most of the time the increase in serum creatinine is mild and it remains there for a prolonged period of time. It doesn't progressively worsen. If that happens, or there are other indications of renal injury like proteinuria, it is better that you get a nephrologist into the picture. So these are few photographs of this patient. The first one is in May 2021, the second in August 21, and the third one is May 2022. And you can see progressively significant decrease in the FDG uptake in the bone metastasis. Same here, you can see a large pelvic deposit, which is healing very well. multiple spine mets which are healing well. And these are clearly seen in these three photographs where there is significant benefit and significant improvement in these patients. So here I have presented a relatively young lady, a 50-year-old lady with extensive bone metastasis who progressed within 1 year or 1.5 years of adjuvant letrozole and treated with abemaciclib with fulvestrant with quite a good response. So shall we go to the next part of it, where I will involve Dr. Shivam, a consultant medical oncologist at SL Raheja Hospital.
Thank you, Dr. Krishna, for a lucid talk, and I was very interested in listening to your case. Especially this creatinine part, we have seen in our practice that only mild increase is there. And sometimes when we go back and look at the drugs, there are some drug reactions, ACE inhibitors or these metformins that we need to change. And then these patients reverse. Very interesting point that you brought up, sir.
So, Shivam, if I can get you into this, so now we have 3 CDK4 inhibitors. What could be the differences, and do you think that inhibition of CDK4 compared to CDK6, is there any differential inhibition, and does this really affect the choice which you make?
Sir, in theory, there is indication that some CDK4 inhibition is preferred by one drug as compared to the other. But whenever we look at the clinical trial data, this does not reflect in the clinical trial data. So as of now, this does not have any implication in my practice. We do see that this has different impact on the side effect profile of a drug. But again, across all trials, all drugs have shown different side effect profile, and it has really not been, beneficial to go by this method.
Fair enough. I think so. Probably the only implication, like you have pointed out, is in terms of side effects. We know that abemaciclib really works 14 times more on CDK4 compared to CDK6. This differential is much more than the other 2 CDK4 inhibitor. CDK6 inhibition actually is the one which results in cytopenias, and probably that is the reason why we have less of cytopenias with abemaciclib. But I think, Shivam, you put it right across, that most of the time there is not much implication. But if somebody already has a little bit of cytopenias, you would probably be inclined to select something which has less of CDK6 inhibition. So the next question is, how important is the overall survival benefit? Does it come to your mind that you need to think about this, or are you comfortable with just seeing a PFS benefit?
So overall survival is very important in my practice. But when we see different trials of 3 different CDK4 inhibitors, different drugs have shown different overall survival. I try to focus on HR ratio, and abemaciclib here has shown a significant improvement in the HR in Monarch 2 trial with a 0.454 hazard ratio. So for me, hazard ratio in overall survival is more important as compared to PFS alone. There is no cross trial, there is only cross trial examination, but these drugs were never head on. So that is not impacting my practice as of now, sir.
Fair enough. I think it is pretty clear that abemaciclib has a good overall survival benefit. And when you're looking at choice of CDK4 inhibitors, most of them are showing some survival benefit. And of course, there is some interesting data on how you interpret some of these trials. So when you put patients on abemaciclib plus hormonal therapy, does it cross your mind that you are trying to delay the initiation of chemotherapy in these patients? Why I'm asking is many of our patients really cannot afford these drugs. And I was surprised to know that even in the US at present, around 20% of the patients cannot afford this and are given first-line chemotherapy in a hormone receptor positive MBC.
I think this concept is changing. We in Bombay at least are not practicing chemotherapy in hormone positive metastatic breast cancer. There are support groups. One of the CDK4 inhibitors have a support group, and the drug is going to become cheaper. patients, when they hear about a cost of a monthly therapy of a 70,000, and in a private practice, chemotherapy would also cost almost the same amount, coming into the daycare session twice in a month, and the CBC and everything associated with it. Most of the patients are now preferring for CDK4 inhibitors. I am not giving chemotherapy in hormone positive metastatic breast cancer as of now. Even if patients are not affording, trying to find out a method, or they're not in visceral crisis, giving them only hormone therapy and waiting for the CDK4 inhibitors to become cheaper. So as of now, no chemotherapy in hormone positive metastatic breast cancers.
Yeah, I think a fair enough point. Ideally, most of these patients or all of these patients who are strongly hormone positive and not in visceral crisis should actually get a CDK4 inhibitor with hormonal therapy. Shivam, your thoughts that there are some papers now, even in visceral crisis, where they have tried CDK4 inhibitors?
Sir, in my opinion, the definition of visceral crisis needs to be revisited, especially in the CDK4/6 era. Uh, Evidence of liver metastasis without overt jaundice, or pleural metastasis without pleural effusion, or a effusion that can be drained and is not rapidly filling. I think these patients do very well with CDK4 inhibitors because the median time to response is close to 4 weeks, 4 to 6 weeks. So I think definition needs to be revisited, sir. And even in visceral crisis, present definition, patient is fit and stable, I rather prefer to start them on CDK4 inhibitors than chemotherapy, which is more toxic.
Fair enough. I think nicely put, Shiva. So, so if somebody has liver metastasis, Shiva, would that be a changer for you in terms of selection of CDK4 inhibitor?
So, liver metastasis in our practice that we have seen is a poor prognostic marker for survival benefit. So I think with Monarch 2 data, especially with the graphs that separated for liver metastasis, we could see that abemaciclib had a better response and a good response in patients even with liver metastasis, and there was a OS benefit. Also, I like the fact that the drug is a continuous usage rather than a breakage, because the breakage is primarily because of cytopenias. Now, if a drug does not have cytopenias, you're able to give abemaciclib throughout the month, throughout the therapy. So I prefer to choose patients with poor prognostic markers, abemaciclib as my first choice, because continuous infusion of the drug and no cytopenias.
Fair enough. So continuity of the drug probably helps in getting more of the CDK4 inhibitor. And that is where probably a differential inhibition of CDK4 probably has a role to play. So does the endocrine resistance status of the patient impact on abemaciclib usage or use and choice of abema?
Sir, I think it just determines the background hormone deprivation that I'm doing. So primary endocrine resistance, we tend to use fulvestrant more, look at these patients for ESR1 mutation. Secondary endocrine resistance, depending upon which anti-hormone therapy they were on. But as of now, based on Monarch 2 trial data, I'm using fulvestrant and abemaciclib in most of my patients who are upfront metastatics.
So when we look at the clinical trial data of Monarch 2, it is pretty clear that patients with endocrine resistance did pretty well when you added abemaciclib. This is in contrast to the trial data, I think, from Paloma 3, where palbociclib actually did not show benefit when added to patients with endocrine resistance, and only patients who had some sensitivity to endocrine therapy actually benefited from palbociclib. So it was very clear that patients with an aggressive disease where abemaciclib showed clear benefit, palbociclib did not. Also, the fact that even when, if you look up patients with these poor risk, that is endocrine resistance, there again, primary endocrine resistance really benefited from abemaciclib, probably telling us that abemaciclib is a pretty strong drug in terms of overcoming this endocrine resistance.
One of the other factors is that the reason for primary endocrine or primary chemotherapy resistance is also PI3K mutation. So what we also saw in the sub-analysis of the group, that even with PI3K mutation, the drug was working. I think this could be one of the contributory factors that abemaciclib was scoring, comparatively better than the other CDK4s in the same group.
Yeah, fair enough. So I think you touched upon this, Shivam, importance of continuous dosing. So which are the kind of patients where you say, okay, this patient really requires a continuous dosing?
So generally, I am choosing abemaciclib based on two factors. One is patients who are likely to have cytopenias, elderly patients, and poor marrow reserve. So they do well with abemaciclib based treatment in my practice. And outstation patients, sir, it's easier for them to explain to them the usage of the drugs. And I don't want them to have cytopenias, come back into the OPD at 7 days, 28 days, and then subsequently. So these are the patients who are ideal in our practice. More and more usage is increasing, so we are finding this drug easily, usable.
And Shivam, there are quite a few data points now to suggest that even patients with brain metastasis, abemaciclib has a quite good response. Your comments on that?
Sir, this was very clear when the subgroup analysis, because the brain metastasis patients were allowed in Monarch 2, and then we could see that there was some response of the drug in the brain metastasis also. The brain lesions remained stable, and it led to an improvement in the overall survival. So I think this is the only CDK4 inhibitor that we now know has some activity in the brain with definitive activity. Uh, Although hormone positive cancer, in my opinion, does not travel much to the brain. Uh, I don't have much patients who have brain metastasis overtly at presentation. They would develop brain metastasis quite down the line, and now Abema is being used earlier. So we don't have much patients in our practice, but yes, there is proof of concept that this drug has a good penetration into the CNS.
Fair enough. So if I understand right, most of your patients now who progress on endocrine therapy would end up with a CDK4 inhibitor plus probably fulvestrant if they were on aromatase inhibitors. And for especially patients with poor prognostic factors like liver metastasis, brain metastasis, who have got a rapidly progressive disease, high tumor burden, your choice probably would end up with abemaciclib. Is that right?
I think so, sir. That's the right way to put it. This is what the practice is presently.
Fair enough. Now, finally, coming to the side effect profile. So, what is your experience with diarrhea being?
I think, sir, this is a very this is a question I think which has concerned me also before I started using the drug. I would relate this to S1 as one of the drugs which has no diarrhea in Japanese patients and has a lot of diarrhea in Indian patients. What other day also we were sitting down with a professor from the Saudi that he was also suggesting that there is very least diarrhea seen in their subgroup of population. I think this is also our experience. Indian patients do not have much diarrhea. And even with immunotherapy that we have seen that we are using the checkpoint inhibitors, our patients relatively have much less side effects as compared to what is reported in the West. I think this is to do with the gut biome, the fact that we have a very probiotic diet. We eat a lot of curd. I think this when this is studied in detail, we would understand that diarrhea is not much of a concern in Indian patients. In my practice, I'm yet to get a grade 3, grade 4 diarrhea.
Maybe a chart from childhood, especially in Mumbai, would help a lot. So I think we have covered most of the points. So I think the experience with abemaciclib in terms of side effect profile has been pretty good. And the diarrhea is what we are worried about. In fact, we give anti-diarrheals with them in hand so that they take it immediately, but it is hardly ever used. So overall, I think abemaciclib is a very well tolerated drug, can be given on a continuous basis, which may probably have an implication in terms of disease control. And it seems to be one of the strongest CDK4 inhibitors in terms of overcoming endocrine resistance. So with that, I thank you for this opportunity. And thanks, Dr. Shivam, for a very entertaining and enthusiastic
Thank you, Dr. Krishna,
questionnaire.
for this nice talk and for these nice panel that you discussed with me. And I would like to sincerely thank Lily for having us as a part of this and the organizers of the conference. It's a brilliant conference organized. Really enjoyed.
Thank you.
Thank you. Dr. Manish, sir.
Hello.
Hello, am I audible?
Yes, sir. You're audible, sir.
Thank you so much for the excellent talk on the CDK4/6 inhibitor. Thank you so much, Somani sir, for giving me opportunity. Now I invite for the resistance part to endocrine therapy. Mutational signature analysis patterns on the genomic instability linked to the resistance of endocrine therapy plus minus CDK4/6 inhibitor in ER positive and HER2 negative metastatic breast cancer. So I invite for this Dr. Pinaki Mahato, Consultant Medical Oncology, SCG Hospital, Vadodara. Over to Dr. Pinaki, sir.
Is my slide visible?
Yes, sir.
Yes.
It is visible. You need to make it full screen, sir.
Okay. So I think we are ahead of time. The topic that I have been given for today to discuss is about mutational signature analysis, which reveals patterns of genomic instability linked to resistance to endocrine therapy plus minus CDK4/6 inhibitors in hormone positive, HER2 negative metastatic breast cancer. This was originally discussed by Dr. Antonia Mara at ESMO this year. So this is a very, very interesting topic because we do not generally discuss about mutational signatures, but we know for a fact that because of numerous endogenous and exogenous reasons, there are basically mutations occurring in various tumor cell lines, and this basically agglomerate and develop different mutational signatures. So we have discussed in literature, there are some mutational signatures that have been described, and these mutational signatures might be prognostic as well as predictive, is what we are going to discuss today. So these are some of the mutational signatures, how they develop, and you can see here that there are some mutational signatures like clock-like or the aging signature. This is the commonest mutational signature that we see across all cancers. The second most common is the apobec signature. That is basically because of some CT-CG substitution mutations that occurs across cell line, and that leads to the apobec mutations. And rest are HRD mutations, MMR deficient, that is immunosensitive, and the smoking-related mutagenic signature. So our topic for today is the apobec cell signature. And this is more commonly seen in certain cancers like breast cancer, lung cancer, head and neck, cervical, and bladder cancers, whereas the clock-like or the aging signature is more common across the other cancers. So which apobec signature? So it is mostly the apobec 3A and the 3B, which are concerned with the mutagenesis in the breast cancer. They will facilitate the acquisition of mutations which cause progression in breast cancer as well. So the study questions here were, what are the pathologic and clinical features of breast cancer which are enriched for this apobec and other mutational signatures? Does it have an impact on the clinical benefit? And what are the genomic alterations which are enriched? So to answer this question, basically we went back to the MSK impact breast cancer cohort. Basically, this is a clinical sequencing cohort of 4,495 breast cancers with clinical and pathological data being available. And this was basically analyzed for the clinical genomic analysis, and from that we could get that different mutagenic signatures. And so here you can see that if you go for the whole genomic sequencing, you can actually understand the mutagenic signatures. But if you go for the targeted panel sequencing, or even if you go for the whole exome sequencing, it is not that evident. So you need to go for the whole genomic sequencing, wherein you can understand as to which mutagenic signature this cancer falls into, and there we can differentiate this apobec signature from the other signatures. And this again has to be done by a machine learning algorithm. So here there was a sigma score that was used, that is a machine learning algorithm, which basically helps us in deciding as to which cluster of mutagenic signature the tumors fall into. And this was the mutational signature analysis of MSK impact, where more than 400 genes were analyzed, somatic mutations, copy number alterations, and mutational signatures were derived from the non-synonymous silent somatic single nucleotide variants in samples with at least 5 SNVs. And what was the dominant signature, or the top mutational signature was basically assessed, and then we were correlating with the other parameters. So you can see here that in the hormone positive metastatic breast cancers, we find more of the apobec and the HRD signatures. You can see that both the above two graphs, they are showing that in the hormone positive HER2 negative or the hormone positive HER2 positive, you can see that the apobec signature is more and the HRD signature also is more. The HRD is also more in the triple negative breast cancer. Here we can see the genomic evolution in terms of the temporal and the spatial heterogeneity that occurs when we treat the breast cancer, and you can see that the apobec actually, it increases once you treat the breast cancer. The apobec mutational signature actually accumulates. And if you look at these patients are the ones who have got a high mutational burden and have got a tumor mutational burden is more than 10, and they have got a lobular phenotype. You can see here. And these patients have a poorer progression-free survival on the first-line endocrine monotherapy. So there is endocrine resistance in the patients who have apobec signature. The green line here shows that there is an inferior progression-free survival with the first-line endocrine monotherapy, as well as if these patients receive the first-line endocrine therapy plus CDK4/6 inhibitors, there also these patients are likely to do poorly. And this is why, because of the higher frequency of the specific genetic alterations such as NF1, ARID1A, KM2C, and PTEN, which are associated with the endocrine resistance. So doing a mutational signature will actually enable us to understand which patients are not likely to respond to the endocrine therapy. And if you look at the mutations also, there are some mutations like PIK3CA mutations and the CDH1 mutations, which are higher in the patients who have got this apobec signature. Here it is again shown the same, and you might have some double PIK3CA mutants as well as in the apobec signatures. So conclusion is that hormone positive HER2 negative breast cancers acquire genomic instability during the T1 evolution, with apobec and the HRD being the main drivers. And patients with breast cancers with high levels of apobec are characterized by high tumor mutational burden. Specific histology like lobular cancers, we know that lobular cancers generally do worse than the ductal. And there are mutations in specific genes like specific PIK3 mutations, CDH1, NF1, and PTEN, which also lead to the endocrine resistance. These patients will have shorter progression-free survival on the first-line endocrine therapy and CDK4/6 inhibitor. They also have, even if the patients have a apobec dominant or they have a HRD dominant, both these patients will have an inferior progression-free survival. So this is again predictive to the response to the endocrine therapy plus CDK4/6 inhibitor. Thank you.
Thank you so much for this resistance pattern. Now I invite Dr. Surdhana Joga sir, Consultant Medical Oncology, Rajiv Gandhi Cancer Institute, Delhi, for a randomized phase 2b study evaluating chemotherapy combined with ipilimumab and nivolumab IO plus IO in metastatic hormone receptor positive breast cancer. Sir. Dr. Surdhana Joga.
Yes. Good evening, sir. Are my slides moving?
Ma'am, just make it full screen.
Yeah, I have made it.
But no.
Just let me once more share it. So.
Yes, ma'am.
Are they moving?
Yes, ma'am. It is full screen. Now you can just scroll.
Okay.
Yeah, they are moving.
Yeah. Thank you, organizers, for giving me this opportunity. So I would be presenting a mini oral session, which was presented by John A. Kite at this ESMO 2022 in September. This is a randomized phase 2b study which evaluated chemotherapy along with the immunotherapy combination, which is the nivolumab and ipilimumab, in the metastatic hormone receptor positive and breast cancer. So when I was assigned this topic, I was thinking of whether I heard, I was reading it right, ICON in breast cancer. So I came to know that ICON there is both in ovary and the breast. So it stands for International Collaborative Ovarian Network in the ovary, and ICON breast, it stands for immunogenic chemotherapy combined with ipilimumab and nivolumab. So that's interesting. And what is the rationale? Usually we think of immunotherapy only in the TNBC setting. So what happened, which is the rationale for developing this study? Actually, this hormone positive, HER2 negative subset of patients who were heavily treated, the immunotherapy as a monotherapy did not fare well. As evidenced in the Keynote 28 trial, the patients had just only 12% response rates, and the results replicated even in the Javelin trial with the avelumab, where only 2 out of 110 subjects who were outside the TNBC patients had responded. So immunotherapy as monotherapy did not work best in these subsets. So they tried the combination, that is the immunotherapy and chemotherapy. The checkpoint inhibitor with eribulin had no benefit in the hormone positive settings. But it was interesting that in the TNBC, the chemo and the immuno combination worked, as seen in IMPASSION 130 and the pembrolizumab trials. And the TONIC trial addressed the question that which chemo is better for inducing the immunogenicity, so that the PD-L1 blockade in combination with chemotherapy could be the best. So this trial found out that the anthracyclines had the maximum immunogenicity, which will have increased efficacy with the subsequent PD-L1 inhibition. So with this background, the study enrolled 82 patients who were metastatic hormone positive, HER2 negative, who had received no chemotherapy or at least 1 line of chemotherapy only. And the limit for the endocrine or targeted therapy was not set. They can receive any n number of lines of endocrine therapy or targeted therapy. And the duration of the chemotherapy received in the adjuvant or the neoadjuvant setting, especially the anthracyclines, which was the common standard drug being used in nowadays, is the DFI should be 12 months. So patients were randomized in 2:3 fashion to chemotherapy only arm, that is the arm A, and chemotherapy plus immuno combination in the arm B. The chemotherapy regimen used was the pegylated liposomal doxorubicin at the dose of 20 mg per meter square every 2 weeks. Whereas oral cyclophosphamide was given every 2 weeks out of 4 weeks with the dose of 50 mg per day. The nivolumab is 240 mg IV every 2 weekly, whereas the ipilimumab it is 1 mg per kg IV every 6 weekly. So the rationale for developing why to choose only this pegylated liposomal doxorubicin, the organizers the study has shown mainly the 3 reasons for that. The liposomal doxorubicin is selected to avoid steroids, and it limits the cardiac toxicity, which is expected with the conventional anthracyclines. And with the conventional anthracyclines, we are also limited by the cumulative cardiac toxicity. The dose is limited to just 6 to 8 cycles. But here with liposomal doxorubicin, with metronomic chemotherapy, it can be given for a longer duration, that is approximately 2 years. And metronomic cyclophosphamide actually counters the regulatory T cells, which are immunosuppressive. So these all factors have put together, and this trial was designed such a way that patients with hormone positive HER2 negative breast cancer would benefit with a combination of chemo and immuno. So the primary endpoints were progression-free survival in per protocol population. So what is the per protocol population? So these are patients who have received at least 2 doses of the PLD and nivolumab, and at least 700 mg of cyclophosphamide, and at least 1 dose of ipilimumab in the arm B patients. So coming to the efficacy, the trial has found that there was no benefit in the progression-free survival with the addition of immunotherapy to the chemotherapy arm. And in fact, the overall survival was also not improved. And in fact, it was detrimental with a hazard ratio of 1.13. When they did a subset analysis also, even in the PD-L1 positive subpopulation, which accounted for 28 patients who were positive for PD-L1 by SP142 assay, there was no PFS or OS advantage. Coming to the secondary endpoints, which is the tumor responses, the overall responses as per RECIST 1.1 criteria, the combination arm had a higher responses, 32%, as compared to 29% only in the chemo arm. The clinical benefit, which is defined as a complete responses or the partial responses or the stable disease until 24 weeks of evaluation, is also higher in the immunotherapy and chemotherapy combination arm, 55% versus 48%. So as with any drug, we are worried about the combinations, how safe it is. So the endocrine related adverse effects were more naturally in the immuno-chemo combination arm, and most of them were the endocrine immune related adverse events, which were hypothyroidism and the hyperthyroidism, and the pituitary insufficiency, that is the hypophysitis, and the adenocortical insufficiency. And the non-endocrine side effects, as expected, were the pneumonitis, hepatitis, rash. They accounted for 2 to 8% of cases. The median duration of treatment was same in both the arms, but the treatment discontinuation rates were higher in the combination arm, which is 12% as compared to 3% in the chemo-only arm. So interestingly, in a subset analysis, they found that patients who had immune-related adverse events of grade 3 or more, when they were analyzed after 4 months, they had a prolonged PFS with the combination therapy, that is the immuno and chemo, with a hazard ratio of 0.34. So the study concluded that the addition of Nivo-EP did not improve the PFS or the OS, but gave more immune-related adverse events. But there are some subset of patients who benefited, that is the ones who had immune-related adverse events. So biomarkers are needed in future to determine the selected subgroups who would benefit with the combination arms. Thank you.
Thank you so much, ma'am. Now I invite Dr. Ankit Agarwal, Consultant Medical Oncology, Gitanjali Hospital, Udaipur, for the randomized phase 2 trial of metronomic therapy, oral therapy, benorelabine plus cyclophosphamide plus capecitabine VX versus weekly paclitaxel as first or second line treatment in patients with ER positive, HER2 negative metastatic breast cancer, the Meteora 2 trial. Dr. Ankit Agarwal.
Good evening, everyone. Can anyone share my slides, please?
Pooja, you have to do this job.
Yes, sir. Surbi, please share the slide.
So, Dr. Sajna, can you meanwhile answer my question in the chat box?
Yes, sir. So, sir, there are one of the few reasons the combination chemotherapy arm chosen also matters with the response to the immunotherapy. In the edazolizumab and the edazolizumab study, the chosen arm was nab-paclitaxel carboplatin, and in the pembrolizumab neoadjuvant setting, there were anthracyclines included. If there were anthracyclines included in the regimens, those immunotherapy trials showed benefit retrospectively based upon the tonic trial, and the IOs which did not use anthracyclines, which just based on taxanes and carboplatins, they did not show benefit. So probably the anthracyclines induce more immune system, they trigger the immune system more rather than the other chemotherapies. This could be the reason for differences between the IOs.
Please go ahead.
Okay. I think the slides are visible, sir.
Yeah.
Good evening, everyone. I'm very glad. I am very grateful for this opportunity. Thank you, Narisa, for this excellent event. So in the next 4 to 5 minutes, what we are going to discuss is phase 2 trial, the Meteora trial, which has a very interesting aspect of treatment in metastatic breast cancer who are hormonal receptor positive and HER2 negative. What it has basically planned to do was it has brought back the oral metronomic treatment in metastatic disease as a first line or a second line treatment, and it has compared it to the standard of care. We have been routinely using weekly paclitaxel in those metastatic breast cancer patients who are ER positive and HER2 negative and who are in residual crisis, basically those patients who need chemotherapy. So can we go back to the first slide, please? So this was a randomized phase 2 trial of oral metronomic treatment that included oral vinorelbine, cyclophosphamide, and capecitabine. That was the VEX regimen. And it was compared with weekly paclitaxel as a first line or a second line treatment in those patients who had metastatic breast cancer and who were ER positive and HER2 negative. Next slide. Next slide, please. So this was the basic background and study design. It was basically the VEX regimen, that is vinorelbine, cyclophosphamide, and capecitabine, was administered in one arm to those patients who had metastatic breast cancer for as long as the patient has the possibility of deriving a benefit from it. And it was compared to the standard paclitaxel arm. So all those patients who had histologically confirmed metastatic breast cancer, ER positive, HER2 negative, measurable or non-measurable disease, but a radiologically evaluable disease according to the RECIST 1.1 criteria, at least 18 years of age with a PS performance status of ECOG PS of at least 0 or 1. Patient should not have received more than one lines of prior chemotherapy for their metastatic disease. The CNS metastatic patients who were symptomatic were ruled out. That was an exclusion criteria. So these patients were randomized in 1:1 ratio. The standard arm was the paclitaxel arm, in which paclitaxel was given at a dose of 90 milligram per meter square weekly, day 1, day 8, 15, and then a 14-day gap. That was a 28-day cycle until progression or toxicity. It was compared with the metronomic regimen, in which vinorelbine was given at a dose of 40 milligram per orally, 3 days in a week. Cyclophosphamide was given 50 milligram on a daily basis, that was continuous, and capecitabine was given 500 milligram thrice a day, and that was continuous. Very interestingly, the primary endpoint in this trial was the time to treatment failure, which takes into account that chemotherapy may need to be stopped due to the lack of tolerability, lack of efficacy, or the patient preference through subjective symptom assessment. And the progression-free survival and the overall survival, the safety were considered as the secondary endpoint. Next slide, please. So these are the patient characteristics. Approximately 69 patients were randomized in the paclitaxel arm as compared to the 71 patients who were in the VEX regimen arm. Median age of these patients were around 61 years, quite comparable in both the arms. One interesting fact was a lot of patients, approximately 46% of the patients, had already received some sort of CDK4/6 inhibitor therapy prior to randomization in this arm. Next slide, please. So the primary endpoint, that was time to treatment failure, the result was the TTF was significantly better in those patients who had received the VEX regimen as compared to those patients who received weekly paclitaxel. The median time to treatment failure was 8.3 months as compared to 5.7 months in paclitaxel arm. And the hazard ratio was 0.61 with a significant p-value. Similarly, progression-free survival was also quite significant in the VEX regimen. Next slide, please. Now, those patients who had received CDK4/6 inhibitor, there was a subgroup analysis. They had shown a quite significant improvement in the TTF, 8.4 months versus 5.6 months, hazard ratio 0.63. Next slide. Progression-free survival was significantly better, 11.1 months versus 6.9 months. 6.9 months was in the paclitaxel arm, and the hazard ratio was 0.67. Although overall survival was not significantly different between the two arms. Next slide. So when it comes to toxicity, obviously the trial showed that those patients who had received the VEX regimen had higher rates of grade 3 and 4 toxicities, but the grade 1, 2 and toxicities were easily manageable. The common toxicities that were seen in VEX regimen was neutropenia. The frequency of target grade 3 plus adverse effects was higher in the VEX group, 42.9% as compared to the paclitaxel group. That was only 28.6%. When we compared both the arms. Alopecia, the hand-foot syndrome, peripheral neuropathy, nausea, fatigue, they were all significantly higher in the VEX regimen arm. Next slide. Now, this trial is an important trial in terms of going back to our oral metronomic treatment as the first line treatment or a second line treatment in metastatic breast cancer patients. It has significantly shown improvement in TTF as compared to the standard paclitaxel regimen. The median TTF was 8.3 months versus 5.7 months respectively. And at 12 months, the TTF was 34% as compared to 8.6%. And PFS was also significantly better in these patients who had received the VEX regimen, although there was no significant difference in the overall survival. Although the grade 3 side effects were much higher in the VEX regimen, but I think TTF and PFS is quite significant. We need to consider that, and probably a larger trial and a phase 3 trial should give us more information whether this type of regimen should be offered to our patients who have a good performance status and who have metastatic breast cancer. Thank you.
Thank you, Dr. Ankit. It's my honor to invite Dr. Hemant Malhotra, sir, Director of Oncology Service, Shri Ram Cancer Hospital and Super Specialty Center, and Professor and Head Department Medical Oncology, Mahatma Gandhi Medical College, for the expert comment after these two phase 2 trial, and also about the CDK4/6 inhibitor debate about the ER positive and HR HER2 negative metastatic breast cancer. Dr. Hemant Malhotra, sir.
Professor Malhotra, sir, is there?
Sir, there is some connectivity issue from Dr. Hemant's side. Actually, sir, Dr. Hemant sir has requested to go ahead with the expert comments from the chairpersons.
Can we request the other chairpersons to make some comments before we move to the next session?
Sir, though there is the two abstract, one is for the, it is again the metronomic therapy is there, and second about the 2 IO plus IO, ipilimumab and nivolumab. But it is for the better to wait for phase 3 study of both in the metronomic therapy, and this IO plus IO is the toxic regimen also, and there is the no benefit of the OS is there, but in some patient is there benefit. And for the CDK4/6 inhibitor, there is the abemaciclib is coming in the next days with more aggressive disease or more visceral disease also in the ER positive and HER2 negative patients. To Dr. Naresh Somani, sir.
Can we move to the next session, please, now?
Yes, sir. This session is sponsored by Novartis. I invite Dr. Ajay Yadav. Ajay Yadav, sir, consultant medical oncologist, SNS Hospital and Mahatma Gandhi Hospital, Jaipur. And it is about the pooled exploratory analysis of survival in patients with HR positive and HER2 negative advanced breast cancer and visceral metastasis treated with the ribociclib plus endocrine therapy in the Mona Lisa trials. Dr. Ajay
Good
Yadav,
evening, sir.
Yeah,
Good evening.
before Ajay starts, let me interfere. There was little confusion in his designation, but
Yes,
I
sir.
think Dr. Ajay, as on today, doesn't need any designation or introduction.
Yes,
He
sir.
himself is an introduction. Presently, definitely, he's working as the senior consultant in the Department of Medical Oncology at Mahatma Gandhi Hospital with Dr. Malhotra and other stalwarts in the field of the medical oncology. Over to you, Dr. Ajay Yadav.
Thank you, sir. So my slides, please.
Would you like to share your screen or you want us to do this show?
Yeah. Can you do it full screen, please?
Sir, this is on full screen, sir.
Okay. So good evening, everyone. So as we know that CDK4/6 inhibitors have been developed a significant improvement in overall survival and PFS in the patients of breast cancer who have metastatic disease and who are positive for hormone receptor and negative for HER2. We have different drugs available today, and we have sufficient data that support that there is significant improvement in survival with these drugs. Today, we will discuss about pooled exploratory analysis of the data of Mona Lisa trials. 3 trials were be included. Next slide, please. Next. So in next 5 to 10 minutes, we will discuss about different 3 trials, Mona Lisa 2, Mona Lisa 3, and Mona Lisa 7. We will particularly focus on the patients having metastatic disease, having liver mets, having visceral mets, and having high disease burden. Next slide. So these are the trial design of different 3 trials. Mona Lisa 2, ribociclib plus letrozole was compared with letrozole alone, and in Mona Lisa 3, ribociclib plus fulvestrant was compared with fulvestrant alone. In Mona Lisa 7, patient population was slightly different. They have included premenopausal patients, and they were randomized to receive ribociclib plus hormone suppression with goserelin, and with versus tamoxifen plus goserelin or AI alone. Next slide. So in this exploratory analysis, median PFS and median OS were evaluated using Kaplan-Meier method in a pooled data set of patients with visceral mets, with liver mets, and visceral mets with 3 or more metastatic sites. And for this analysis, first-line patients were analyzed separately. Next slide. So these are the baseline characteristics of the patients. We can see that both the arms were well balanced in terms of age, performance status, number of metastatic disease, site of visceral mets, and the treatment they received in first-line setting. Next. So this graph shows PFS and overall survival in the all patient population having visceral metastasis. Here we can see the progression-free survival curve. The curves were well separated from the beginning, and there was significant improvement in PFS. With hazard ratio of 0.61, the median PFS was 22 months versus 12 months in the endocrine therapy alone arm. And there was 39% reduction in the risk of progression in the patients who received ribociclib in combination with endocrine therapy. And this curve shows overall survival. There was significant improvement in overall survival also. It was 49 versus 46 with hazard ratio of 0.81. So this was about all patients having visceral mets. Next slide. This subset was the patients who received this therapy in first line. So patients who received therapy in first line, there was significant improvement in PFS, and the PFS was 29 versus 14 months with a hazard ratio of 0.56. Means there was 44% reduction in the risk of progression, and there was survival benefit also. The overall survival was 63 versus 51 months in endocrine therapy alone now. Next slide. So this graph shows the patients who were having liver metastasis. The patients who had liver metastasis, they were also benefited, and there was significant difference in PFS and overall survival in this patient population also. Next. Now, if we see the patients who were having liver metastasis and who received this drug in first line setting, the previous slide was about all patient population, but this was about the patient who were having liver mets and who received the combination in first line setting. So there was significant improvement in PFS, 16.7 months versus 9.8 months with hazard ratio of 0.55. And for PFS, the hazard ratio was 0.77. Next slide. These graphs are for patients who are having 3 or more metastatic site, and the PFS and OS both were improved among the patients who have, and the population of these patients were around 31%, and they were also benefited with combination. Next. This shows DFS and PFS and overall survival in patients of 3 or more metastatic site, and the drug was using first line setting. So in this population, the PFS was 24 versus 14 months, and OS was also improved. Next. So next point is regarding the toxicity of drug. When pooled analysis was done, the authors found that the toxicity profile was similar among the different patient populations, and it was consistent with the previous trials where the data was analyzed separately. There was no difference in terms of neutropenia, nausea, vomiting, and all subsets of patients having liver mets, patients having visceral metastasis, patients having high disease burden, there was no significant difference in the toxicity in these patients. Next. So with this pooled analysis, we can say that the visceral mets has had a 44% reduction in the risk of disease progression and 22% reduction in risk of death. The patients who have liver mets, there was 45% reduction in the risk of disease progression and 23% reduction in risk of death. Patients who have visceral mets with high disease burden, there was 41% reduction in risk of disease progression and 20% reduction in the risk of death. So this trend of this shows that ribociclib benefited all the subset of patients, and the toxicity profile was not different from the individual trials. So we can conclude that the patients with visceral mets or liver mets, they experience a clinically meaningful survival benefit and OS benefit with the combination of ribociclib plus endocrine therapy, and it is an effective therapeutic option in these patient population. With this, thank you everyone for sparing time for this activity. Thank you, sir.
Thank you so much, sir.
So with the permission, can I announce one thing? As we have made the prize announcement also, so through this message, I will be requesting everyone, whether it's a delegate, faculty, or the participant, that they make some thoughtful questions or some other things in the chat box, so that can be judged for the prize winning category. So anyone can participate in that. Thank you.
Yes, sir. So in breast cancer oncology, last topic with the HER2 low expression, targeting HER2 low expression in breast cancer, evaluating the evidence, challenges, and opportunity for expanding treatment benefit to the more patients. Dr. Bharat Vaswani, sir, Senior Consultant Medical Oncologist and Hematologist, Yashoda Hospital, Hyderabad. To Bharat, sir.
Yeah. Am I audible?
Yes, sir.
Yeah, just let me share my slides. And most importantly, are my slides? Are slides visible? Are my
Yes, sir.
slides?
Yes, sir.
Okay. So let me thank Dr. Somani sir, whom I can call my brother, for the kind invitation, and all the organizers. Now in the next 15 minutes, I'll be just discussing probably for me the most important practice changing abstract, or probably the most important thing that we'll be seeing in the future, a single trial which has changed the destiny of around 45 to 50% of breast cancer patients. Some new controversy arising, but I think so this for me was probably the most important trial. I'm very brave enough to say in this year, if you consider all the trials taken together. Let me start with a trivia question. Who is this fair lady? Because the clue is she's the lead author of the main Destiny 4 study, and probably that is more important. The good thing was she was an Indian, and just the appreciation, she is a professor, breast oncology, MSK. Probably she was the main person who did additional HER2 new pie chart. Now, before this study, or till I can say till February, March, April, what we used to categorize was HER2 new amplified, which could be 20, 30%, but anyway less than 30%, and remaining 70 to 80% was HER2 new negative. We were least bothered about 1 positive, 2 positive. What was important is 3 positive or FISH amplified thing. But there came the new concept of HER2 new low. So how do we define HER2 new low? So 1 positive IHC or 2 positive with in situ hybridization negative. This constitutes around 45 to 50% of all our breast cancer patients, and that is important. Now, what we had was, currently there are no, still this drug came, there was no currently approved targeted therapy. Now, majority of these HER2 new are ER/PR positive. So 80 to 90% of this HER2 new subset in a general population will be associated with hormone receptor positivity. So the first take-home message is, if you are hormone receptor positive and your expression of ER/PR positive is high, so the chances of you having a HER2 new expression is very high, of the order of 60 to 70%, against a ER/PR negative where this HER2 new expression is low. If you remember your CDK4/6 trials, first line PFS 14 months, and when you remember your second line PFS, basically if you remove your alpelisib study, which was 7 months, it is 4 to 5 months. So this drug really, and if you see the difference, talk about HER2 new low, no benefit of HER2 new blockade. The first thing to remember, the effect is what we call as through an antibody drug conjugate, and that is also a bystander effect. So the word bystander is more important. You don't need to block the oncologic signal. You need to deliver this drug in that cell. And let me start with the history. What is the medication used till now to treat this? So initially trastuzumab was tried, but only 1.5 months PFS and a response of only 2.5. It failed. And then TDM1. So all these drugs fail in this HER2 new low subset. And then the destiny change, and that is what I am trying to present. Now, trastuzumab deruxtecan, this slide has been discussed in various forums. The most important thing or a major difference with this drug is a higher drug to antibody payload, and more importantly, an effect of bystander anti-tumor effect. So this topoisomerase 1 inhibitor can penetrate your cell membrane and can go outside and kill the surrounding cell, which property has not been documented by your trastuzumab or a TDM1. So try to concentrate on 6 number. So a drug goes inside, dissociate, the topoisomerase comes, kill cell. But what was important was this drug or this topoisomerase 1 can permeate your membrane and go outside and kill the surrounding cell. And that is probably the most important effect of this HER2 new subset. It's all started. In fact, this was one of the very few phase 1 study which gained a lot of attention. And in fact, it was published in JCO. So
57, 54 patient with HER2 of 1 to 2 positive. 37% response in the 8th line. Please remember 7.9 line median and a PFS of 11 months. I have never remembered the data in the 8th line which give you a PFS of 11 months. And based on this unprecedented, there was never a phase 2 trial. From 1, it directly went to phase 3 trial. And that was probably the topic of today's discussion. Destiny Breast 04 study. The population, again, the thing I told, HER2 1 positive or 2 positive with ISH negative. The dose was 5.4 milligram per kg every 3 weekly. Please remember, the primary endpoint was for hormone receptor positive patient. Now, I have attended a lot of debate that this is not the right. What about hormone negative patient? Please remember, when you talk about your HER2 no leptide, only 10 to 20% in the ER/PR negative will have a HER2 no expression. So in the general population, only 90% will have some degree of hormone receptor expression. The second endpoint in overall population, I will like you to concentrate on the target population. 3 lines of treatment majority have taken. So it was the 4th line. Majority of them had taken, 61.13% had taken at least 1 line of chemo, and majority have taken at least 2 lines of hormonal. So these were hormonal refractory. More importantly, one thing I tried with CDK4/6, 70% had taken. So if you compare yourself with a BILEAV study, if you remember your alpelisib, that is what, so a heavily treated population. Now this was unprecedented. Remember your phase 1 data, 11 months. The progression-free survival in the primary subset was 10.1. An absolute gain of 4.7. Please remember 4th line with a 49% reduction in the risk of progression. But again, the same thing has been echoed by overall population. In fact, it was better in the overall population. So what we found out was the first phase 1 and phase 3 data was more or less equal, which is rarely seen in clinical practice. Now, this was the icing in the cake. A drug in a 4th line with a median overall survival of 2 years, 23.9 months, absolute gain of 6.4 months with a 36% reduction in the risk of death in hormone receptor positive, and the same quantum of benefit in all the patients. So here was one of the studies which in a 4th line gives you a 2-year overall survival with nearly 11 months of progression-free survival, which was never heard of in any of the studies. Hormone receptor negative. The quantum of benefit was better. Your hazard ratio is 0.46. So 54% reduction in the risk of progression. And more importantly, when you talk about overall survival also, this quantum of benefit remains the same. The absolute gain is 9.9 months. So if you remember your Sacituzumab data also, remember 12 months was your TROPIC study. It was 18 months. So a drug which works very well in a 4th line, giving you overall survival. Now affected or will impact your practice. This is the most important. So even if you have taken your CDK4/6 inhibitor, your PFS still is 10 months. Remember your 2nd line treatment in breast cancer in post CDK4/6, it was only 7 months, and this is the 4th line. If your IHC is 1+, still your PFS is 10.3 months. If it is 2+, it is 10.1 months. If you have taken 1 line of chemo, it is 10.9, and if you have taken 2 or 3 line, it is still 10 months. So see the quantum of benefit in a phase 3. Probably after 1st line, I think so in any of the subset, this may become the 2nd line, and in due course, because even in the 1st line, if you have any degree of your HER2 positive. So this was unprecedented. 10 months PFS, 2nd line C, all your post CDK study, this was never heard of. Is the drug safe? So 3% grade 3 toxicity, but more importantly, how many discontinuations? 16%. So 1 in 6 or less than that, and only 4% death. The commonest cause of discontinuation was ILD, and the commonest cause of dose reduction was a hematological, probably due to that topohistological, followed by nausea, fatigue, followed by your diarrhea and constipation. Now, more important significant toxicity of interstitial lung disease, see your grade 4 and 5, 0.8%. Ejection fraction disease, grade 4, 5, 0. And cardiac failure, grade 4, 5, 0. So a safe drug probably, and we all know this. So what this study showed was first HER2/neu targeted therapy to demonstrate improved efficacy in this. This was unprecedented, 50% potential improvement, your hazard. And probably there is no doubt, I think so, in this 50% of the patient, this is now the standard of care, or this drug will definitely be used. Second line, when I have shown you for both CDK4/6, but yes, drug once is critical issue. What this trial have changed. So this was the old concept. We never used to look whether 3+ or FISH amplified, but now the pathologist role will increase. You need to tell, pathologists need to tell, is it a 0 or 1+? As I'll be telling you, even in 0 now they have to decide whether it is ultra low or low. So any HER2/neu positivity being a bearable, you need to be reported, because here the drug works very well, as I'll be telling in future. So the pie chart, if you see, HER2/neu positive 15%, you already use this. In HER2/neu low, which is 45 to 55% of the patient, you'll use this drug now, definitely. And in this 30 to 40 also, I'll be telling what is the future now for this subset of patients. The most two important challenges are important is HER2/neu expression is unstable. See the left part of thing. In a primary, if the HER2/neu is low and if the disease become metastatic, it may still come as 0 in metastatic. Similarly, if HER2/neu is 0, even metastatic, it may become low. So that is more important now, that probably there are multiple factors contributing to it. But the most practical definition now that I have suggested is, if you had your HER2/neu non-amplified, but any expression in any time, so even in primary, if you had your HER2/neu, or even in metastasis, if there is any one positivity, please use this drug, because that expression is unstable and you will get the benefit of this drug. So this comes down to 81%. Please remember, this is more important. And the second challenge comes is 0 and 1+. If you look into pathologists, one pathologist may report 0, other may report 1+. Because if you say 0 is less than 10% cell, barely seen. And even in this subset, which is called as ultra low, I'll tell you the data that is very encouraging. So probably that is more important now. Producing what she told. This was a trial in HER2/neu 0 subset, a DAISY study, which was presented. Now, if you leave, it was the duration of response, PFS was 4.2. Please remember, it was again a 7th line, and your duration of response was 6.81. Please remember, it was 0. The main premise is, even if you have 0 thing, it is less than 10% of the cells, if you say, that has some degree of expression, you consider it as 0. So here comes the study which might again change the practice. Destiny 6 study, where they are seeing in HER2/neu ultra low. So even if it is 0, any sort of your HER2/neu on IHC, if you have, you can give this drug against physician choice. So probably this is a subset we know in this setting. And a Destiny 8 study, where we are combining this TDXD, which is deruxtecan, with capecitabine, with the immunotherapy, with capivasertib, which is a AKT inhibitor, with a hormonal therapy, and with a fulvestrant. So in the future, you may see a combination of TDXD with all these drugs. You may use it in ultra low also, based, because phase this 0 also there was some response. Is it only the drug which has been used? So there are multiple antibody drug conjugate. More important being diocarbazine and disitamab vedotin. Actually, please remember this drug, I have presented a data in urinary bladder. The same HER2 low, there was a response of 40% with the PFS of 5.7 months, I beg your pardon. But again, you will have multiple drugs in future, all based on antibody drug conjugate, which you may target this. You may probably sequence it also once you have this data available. Other drugs probably experimented who are being given in selective HER2/neu population. Needless to discuss, but in future you will have 4 to 6 drugs which will be targeting the same subset of patients. And probably the future of this subset is also exciting and may get crowded in future. So this is what today with Destiny 4 you are covering another 45 to 50% of patients. Let us wait for Destiny 6 and this ultra low subset also. You may start targeting with trastuzumab deruxtecan. Here there will be probably, when you see what is being suggested, that in case of mass spectroscopy, that every breast cancer patient may have some degree of RNA expression of HER2/neu. And so in future, probably, irrespective of whether she's positive, negative, you might use this drug in all the subset. Maybe the quantum of benefit may be different. But as the future going, you have covered your 45-50, another 15% with Destiny 6 probably will be covered, and the remaining probably in future with newer modality of detecting it, mass spectroscopy, you will have this more. The last part, does TDXD has a CNS activity? You discussed in 3 positive tucatinib. Please remember, this drug also has a very good activity in brain. If you see the 3 trials that were presented in this year, ESMO, in SABCS, 73% response, 44% response, and 73. Please remember, these were active brain metastasis. So based on this, I have not written it, but DEBRA trial, DEBRA-2 trial has been conducted now, which is including these brain mets in HER2/neu low subset, and they are trying this TDXD. So probably added advantage in those with brain met with this drug, considering what we have gotten 3 positive. So if I have to summarize, HER2/neu low, I remember ultra low also I have told, and the data that has been presented. Please remember, I'm just presenting the data what Shanu Modi madam presented. Novel antibody drug conjugate delivers highly potent cytotoxin to HER2/neu expressing thing, any amount of HER2/neu, with clinically relevant activity observed in the metastatic setting. The diagnosis of HER2/neu remains challenging, given that IC scoring was never developed to detect these things. Please remember, it was for 3 positive. Now, the onus is on pathologists to report it. And in future, we'll have a lot of RNA-based technique, any amount of HER2/neu in RNA, and you need to give this drug. Now, the most need of the hour is the novel HER2/neu assays, and results from ongoing this Destiny Breast 06 may change our definition of HER2/neu. So it was more than 10% any, but now in less than 10 also, you might have to consider any HER2/neu to be HER2/neu low. And last but not the least is, we need extensive flexibility to adapt to future evolution of the definition of HER2/neu. Probably more exciting data coming our way, lot of encouraging data which has been replicated, and for me this was the most practice changing or the most important subset that may change the destiny of our breast cancer patient. This was the last slide. That was, if you have time, go through ESCO 2002. What is our destiny? Should standard of care of patient with HER2/neu breast cancer change as a result of Destiny 4? The answer is absolutely a big yes. But we need more sensitive tool to better define the most appropriate patient population. I thank Somani sir and the entire team for a kind invitation. Thank you all.
So there was a question in the chat box that being the dynamic marker, should we use the repeat biopsy to find out the low versus ultra low, something like 0 or 1, or if it is that coming 2, then do the FIS again. This was probably the question by Dr. Anuraj Purohit.
Sir,
would you like to answer this question?
Yes, sir. Absolutely. Sir, what I'll tell is it could be dynamic, but if it is positive at any point of time in the course of disease, you have to consider it and start treatment. So not present doesn't arise. The practical definition they suggested is, if there is presence in a primary or metastatic, please treat it with this drug. So should you do a biopsy? The answer is yes, you should do it, but probably the drug choice should not change. If you had positivity, what we now know is even in ultra low, it works. So why should you deny your patient the chance to give a good drug, which I feel might change all the paradigms in the future? If you say your 11 months PFS post CDK4/6, this has never been replicated. In fact, it was a 4th line and 2 hormonal, 3rd line hormonal. So for me, you should do your HER2/neu, even if it is negative in metastatic, because being a dynamic expression, probably it could be several reasons that it could be negative. Your fixation problem, probably the method that you have used. So I will not deny my patient, but I may do it because the quantitative benefit will be better. Higher the expression, more will be your PFS. That maybe that also in 3 positive, not in 1 or 2 positive, because in both these subsets, the PFS was more or less the same.
Thank you.
Thank you, Bharat sir, for this exciting new therapy about the HER2 low and ultra low therapy. There it is the most exciting and practice changing abstract of this year. Now we move on the genitourinary cancer session 3. So I invite Dr. Vamsi Krishna sir, Director and Head Medical Oncology and Hematology Institute of Oncology, IIT Hospital, Hyderabad, and Dr. Vinit Talwar sir, Director, Department of Medical Oncology, Rajiv Gandhi Cancer Institute, Delhi, for further proceedings. Thank you, sir.
Is Dr. Vinit Talwar here?
Good evening.
Good evening.
Good evening, sir. Good evening, sir.
Good evening. So once again, I thank Dr. Somani for giving me this pleasure. And is Dr. Vamsi there? Any idea, Naresh, if Vamsi is there?
Yes, he must be here.
No, sir, he's not there.
So if that is the case, can we go to the talk straight away?
Yes, sir.
So then I will introduce Dr. Palak Bhatt, who is a consultant medical oncologist at the Oncoven Cancer Center, Ahmedabad. And he'll be delving on the topic of pembrolizumab and olaparib versus abiraterone or enzalutamide for patients with previously treated metastatic castrate-resistant prostate cancer. This is the KeyLink 010 study, which was a randomized open-label phase 3 study. So, Dr. Bhatt, please.
Thank you very much, sir, for invitation. Today we are going to talk, as sir said, about KeyLink 010 study, which is open-label randomized trial about pembrolizumab plus olaparib versus abiraterone or enzalutamide. Next slide, please. Hello. Yeah. Next. So in this study, key eligible criteria were histologically or cytologically confirmed mCRPC cases, patient who has progressed on either abiraterone or enzalutamide, but not both. So either of drug patient, if taken, then we can taken into consideration for this study, or patient also taken docetaxel for primary treatment. ECOG performance status was 0 or 1, and tissue sample for biomarker assessment. Stratification factors based on either patient has taken abiraterone or enzalutamide and any measurable disease at baseline present or not. So ratio were divided into 2:1. 529 patients were taken in pembrolizumab arm. Pembrolizumab is given up to 35 cycles maximum. And in abiraterone or enzalutamide arm, 264 patients were taken. Dual primary endpoints were radiologically progression-free survival and overall survival. Secondary endpoint were time for first starting of treatment and overall response rate and safety. Next slide, please. So baseline characteristics and patient are almost similar. 54 patients are in pembrolizumab group are has taken abiraterone, and around 54 same patients has taken previously same abiraterone. Enzalutamide is 45% of the patients. In majority of the patient, Gleason sum score was greater than or equal to 8, which is 69% in both arms. Other we will focus on BRCA status and PDL1 status. BRCA mutated patients were around 9% and non-BRCA mutated patients around 83% in pembrolizumab arm versus 78% in any hormonal treatment arm. CPS score, PDL1 CPS score less than 1 in 69% of the patient of pembrolizumab arm versus 74% in hormonal arm. CPS score more than equal to 1 in 24% of the patient in pembrolizumab arm. Next slide. So primary endpoint in this study was progression-free survival, radiologically progression-free survival. In pembrolizumab plus olaparib arm, median survival months was 4.4 months, whereas in hormonal arm, this median survival months was 4.2. So these are almost similar. There is not much changes, but we can see that in patient with BRCA mutation, which is ratio is more favorable in pembrolizumab arm because of olaparib. We generally used olaparib in BRCA mutated patient, and this progression-free survival is more effectively we can see in BRCA mutated arm as compared to non-mutated arm. Even in PDL1 status, CPS score less than 1 has less favorable factors as compared to the CPS score greater than equal to 1. Next. So primary endpoint based on overall survival in pembro plus olaparib arm is around 15.8 months, whereas in hormonal arm around 14.6 months. So this is again largely similar. And hazard ratio, when we see it is more favorable in BRCA mutated arm when we see pembrolizumab plus olaparib arm as compared to non-BRCA mutated status. And in PDL1 high status, when CPS score is greater than equal to 1, hazard ratio is more favorable for pembrolizumab arm. Next slide. Secondary endpoint. When we see secondary endpoint, median months is 7.2 for pembrolizumab arm as compared to 5.7 in hormonal treatment arm. And in majority of the patients starting for the second line treatment, cabazitaxel or enzalutamide, abiraterone, carboplatin or docetaxel. These are the subsequent lines of the treatment that has been used. Next slide. Secondary endpoint, overall response rate. When we see overall response rate in pembrolizumab arm, it is clearly much higher, 16.8% of the patient as compared to in hormonal arm around 5.9%. DCR is again higher in pembrolizumab arm, 32.4 months as compared to 19.3 months in hormonal arm. Here we can see this complete response in C is seen around 1.6% of the patient. When there is none of the patient gets complete response with hormonal treatment. In day-to-day practice, when we use immunotherapy, we generally see such kind of magical response in 1 or 2 patients out of 10 when we treat with immunotherapy. So similarly, we can see this finding here as well. Partial response even seen in 15% of the patient in pembrolizumab arm versus 5.9%. For stable disease seen in almost similar percentage of the patient. Next slide. Secondary endpoint, safety. In pembrolizumab arm, obviously we can see higher rate of the adverse event because of a majority of the side effects are related to olaparib. Around 57% of the patient develop more than equal to grade 3 disease, grade 3 adverse event. In hormonal arm, around 39% of the patient develop such kind of the adverse event. This adverse event led to discontinuation of the treatment in 15% of the patient in pembrolizumab arm, as compared to only 3% of the patient in hormonal agent. And death related to treatment seen in 4% of the patient in pembrolizumab group as compared to 2.3% in hormonal group. So we can see this olaparib arm has more side effect as compared to hormonal treatment, and the majority of the side effects are anemia, fatigue, nausea, and decreased appetite. We generally see that olaparib patients have more fatigue, and which is very difficult to treat and counsel the patient when patient is on olaparib. Next slide. So conclusion of this study is in majority of the patient, primary progression-free survival and overall survival in pembrolizumab arm and in comparator hormonal group are almost similar. But when we see overall response, which is higher in pembrolizumab group as compared to olaparib, and this study is has more adverse event in pembrolizumab, and majority of the adverse events are related to olaparib. Other ongoing studies are also there, like with different combination of pembrolizumab and olaparib in various prostate cancer. Thank you.
Thank you, Dr. Bhatt. And unfortunately, this combination of immuno-oncology drugs plus the PARP inhibitors was a negative study. And at the outset itself, it enrolled unselected patients. And most of these patients were heavily pretreated. So probably that was one point which was against it. And even if you look at the biomarkers, about 30% of patients were the ones which had PDL more than 1. And if you look at the flip side, the BRCA positivity was just, I think, 8 or 9%. And so was the HRR positivity, which was about 25%. So even if you add both of them, 25 plus 9, say about 35% patients were the ones which had the biomarker assays positive, and 65% were negative. And the 70% of patients were PDL1 less than 1%.
Yeah.
So probably that was the reason why it did not translate into PFS or OS. Talking of the overall response rates in the ORRs, you find that although there is some benefit, but when you come to the actual hazard ratios, it was about 0.86. And that, to my point of view, would not be that significant if you have to call this as a practice-changing study, even if the trial is positive. So probably that is why, which Dr. Bhatt mentioned as the last line of the conclusion, that we're looking at other combinations of pembrolizumab with something else and olaparib with something else. So probably that's the reason why this study did not mature the way it was supposed to be. And we require good biomarkers to assist us in coming to a positive conclusion. So I think with that, I'll conclude this. I thank Dr. Bhatt, and back to the organizers.
Thank you.
Thank you, sir. Now I invite the chairpersons. Dr. Shyam Agarwal, sir, Director Medical Oncology, sir, Gangaram Hospital, New Delhi, and Dr. R. Rangarao, sir, Chairman, Paras Cancer Center, Paras Hospital, Gurgaon. Over to Dr. Shyam Agarwal, sir, and R. Rangarao, sir.
Yeah, good evening, everyone. Is Dr. Rangarao there?
Good evening, sir.
Yeah.
No, sir, not yet.
Okay, so I'll start the proceedings for this session. Thanks to the organizers for giving us this opportunity to join on this educational program. As you see, there are 3 lectures in this particular session. The first one is sponsored by INTAS, and it's a lecture by Dr. Sudhir Palsania, who is the medical oncologist in Jaipur Shalby Hospital. And he's going to cover an important topic, that is the role of chemotherapy in patients with hormone-sensitive prostate cancer. So I hand it over to Dr. Sudhir for his lecture.
Thank you so much, sir. And thank you, Dr. Naresh Somani, sir, for giving me this opportunity to present this topic. Kindly share my slides, please. Can I start, sir? The role of chemotherapy alongside the hormonal treatment in the metastatic hormone-sensitive prostate cancer. Next slide, please. So there is a benefit of the chemohormonal therapy we discussed in the metastatic hormone sensitive prostate cancer, high volume versus low volume disease is there. Then there is the androgen receptor pathway inhibitor in combination with docetaxel in the management of metastatic hormone sensitive prostate cancer, HSPC. Choosing between in the 2021 guidelines, there are the docetaxel and androgen receptor pathway inhibitor in the metastatic HSPC. Now there is the role of doublet and triplet combinations also, and utility of PSA also. And there are the ongoing phase 3 trials of editing metastatic HSPC. Next slide, please. So this is the first slide of the chemohormonal therapies in the metastatic hormone sensitive prostate cancer. Next slide, please. So they are the OS results from phase 3 trials of editing the CSPC trials. They are the many trials about the charted, Stampede, Latitude trials, all about the docetaxel chemotherapy, and then there is the ARPIs. They are the Titan, Arches, and Enzyme trials. They are all about the sensitive prostate cancer. So it is better to understand all about the ADT with ARPI with the chemotherapy. Now they are the combination therapies, the doublet or triplet therapy about this, and the docetaxel alone also. Next slide, please. So there are the major trials are the charted trials, high volume versus low volume disease. They are the median follow-up around 53.7 months in metastatic hormone sensitive prostate cancer. This is the ADT plus docetaxel is around 51.2 median OS is there, and in ADT alone is only 34.4 in the high volume disease. Next slide, please. And this is another trial of the docetaxel chemotherapy. Get GTUG FU15 trial, high volume versus low volume disease is there, and again there the median dose overall survival is more with the ADT plus docetaxel. It is 39.8 months. In the low volume disease, there are the ADT plus docetaxel is 69.5. It is not reached this there. Next slide, please. And this is the third trial. That is a Stampede trial. It is various arms. One arm is there with docetaxel. Next slide, please. So interpretation of these three trials are the volume status does not relate to sensitivity to docetaxel, but there are the two trials. One is the charted and second is the K2G AQ15 trial. They said could separately differ the treatment with docetaxel until the progression to CRPC. So they established the treatment of the chemotherapy docetaxel in high volume disease. Then there is the Stampede trial that benefited the early docetaxel regardless of volume status. So hypothesis related to greater number of patients with de novo rather than the recurrent disease in Stampede, and they benefit from the docetaxel in low volume as well as high volume disease. Next slide, please. And there the androgen receptor pathway ARPIs in the combination with docetaxel. They are the combination therapies and with the ARPI with docetaxel in management of MSHPC. Next slide, please. So there are the three trials, Titan, Arches, and Enzyme. In all the three trials, there are the few patients who received the prior docetaxel. So in the Titan, there are the ADT plus apalutamide, then the enzalutamide, and Enzyme also for the enzalutamide with ADT plus enzalutamide. It is placebo in the Arches trial, and Enzyme trial it is the non-steroidal androgen inhibitor are there. Next slide, please. So this is the Titan trial. Apalutamide is also showing the benefit in the OS, final OS trial. So there is the prior docetaxel in the 28 patients, and it is not reached there the apalutamide. OS is median OS is not reached, and in the prior no there is the 48.7 months without the apalutamide. Next slide, please. Next slide. This is the Arches trial. There are the low volume disease, high volume disease, no prior docetaxel, and the prior docetaxel. So it is also show there around the 24 months also, 36 months also, and 48 months also. So with the docetaxel, they are prior received, there is the more survival advantage. Next slide, please. The same is the Enzyme trial also. Next slide. Next slide. So there this is the guideline. There is the choosing between the docetaxel and ARPI in the metastatic HSPC. Next slide, please. So this is the Stampede trial. They are standard of care with abiraterone acetate or standard of care of with docetaxel and prednisolone. So next slide, please. So in the board, they are the favors the standard of their overall survival is fair the docetaxel and prednisolone arm. Next slide, please. So there are in the abiraterone arm, we see that 82% is prostate cancer and 80% are the death causes are other than the prostate cancer. Next slide, please. So according to these old trials, next slide. Now there are the doublet therapy for the HSPC. All eligible patients should be offered treatment intensification upfront. And choice of agents are the, as we prior seen, docetaxel, abiraterone, apalutamide, and enzalutamide. So there the docetaxel is available, abiraterone is available, enzalutamide, and the apalutamide. Subgroup analysis from Stampede also support the RT2 prostate in conjunction with ADT for low volume disease. Next slide, please. And next slide. So this is the new trials out there. The PEACE-1 trial. PEACE-1 is amended to allow for evolving the SOC. And docetaxel as a stratification is used there. Next slide, please. So PEACE-1 trial is there. The PFS on OS with abiraterone with the docetaxel plus minus radiotherapy in the population is there. So SOC is docetaxel with abiraterone. There is the P value is less than 0.001, and there with the abiraterone there is the PFS is more and OS is there. Next slide, please. So OS with this metastatic burden is high or metastatic burden low. So there first trial for the abiraterone in conjunction with docetaxel. Next slide. And grade 3 to 5 reported in editaxel and docetaxel. They are the main difference in the only one thing is there. If the abiraterone and docetaxel both are used, then the liver side effects are more around 20%, 6%, and in the only docetaxel only 2%. This is the only side effect which is more seen in the combination therapy. Next slide, please. So addition of abiraterone to standard of care ADT plus minus docetaxel significantly prolong PFS, different PFS and OS also. No evidence of differential benefit with the ADT alone versus the ADT plus docetaxel alone. Well tolerated only for the elective abnormalities. Next slide, please. This is the second trial, Erasmus trial. There are glutamide in MS facing this new drug. There are the docetaxel with darolutamide and ADT plus docetaxel with placebo. And primary endpoint is overall survival. Next slide, please. So primary endpoint with the overall survival, addition of this darolutamide to ADT plus docetaxel significantly lowered risk by the 32.5%. Next slide. So OS benefit treatment intensification is there. The docetaxel is there. Then the charted is Stampede. Then the abiraterone plus docetaxel, and last is the darolutamide plus docetaxel is there. And hazard ratio is 0.62 to 0.68. Next slide, please. And this is the 7-month PSA. This is the prognostic marker that is marked in the charted trial. Next slide. OS benefit for adding to abiraterone or newly the darolutamide to ADT plus docetaxel does not address benefit of adding to docetaxel to ADT plus ARPI. And they are the adaptive approaches for both the therapies. Next slide, please. So now those 2021 treatment, there are the treatment guidelines, the like the ADT plus one of these abiraterone, apalutamide, enzalutamide, or docetaxel. Next slide. And now in the 2022 with these data, they are the patient with metastatic castration-sensitive prostate cancer, ADT plus, if chemotherapy is not preferred. Why? They are the consideration like the chemotherapy fitness, symptom burden, post, low versus high volume diseases, histological, morphological features like poorly differentiated genetic features, and GEP is also there in the data in the 2022. There are option of abiraterone, apalutamide, or enzalutamide, or nonmoving darolutamide. And if chemotherapy is preferred, there is the data of the docetaxel plus abiraterone or docetaxel plus darolutamide. This is the GSS 2022 data. along with the denosumab every 6 monthly or zoledronic acid, only for the patient with the 10-year risk factor more than 3%, not for the all patient in the CSPC. Next slide, please. So there is the data for the docetaxel previously also for the single therapy, now with the doublet therapy also, and local therapy to primary and RT to oligomers with the like the stamped source. Sorry. Next slide, please. They are the ongoing phase 3 trials. Next slide. They are the Aeronaut, keynote with the pembrolizumab, sorry, and with the abiraterone also. Next slide. So now there are the in the docetaxel arm there are the no data about the nano-equally formulations, but they are approved in the breast and they are coming in the prostate also. So something like conventional taxane formulations, organic solvent is there. So there is the hypersensitivity reactions. The grade 3 and 4 hypersensitivity reactions are not a major concern in nano-equally formulations, and adverse effect due to the steroid premedications are less. And neurotoxicity, there are no data, but there is equivalence in the convenience and nano-equally in both of them. This is the also there are the in the CSPC we use the hormonal therapy with the chemotherapy, and chemotherapy arm is better in the high volume disease with the combination or alone. Next slide, please. So conclusion is there that treatment intensification in metastatic hormone sensitive prostate cancer is associated with OS benefit and should be offered to eligible patients only. And in patient plan to the upfront docetaxel, we can add abiraterone or darolutamide if approved as a triplet therapy is associated with the ADT. So it is triplet. It is associated with OS benefit, but optimal patient selection and timing is unclear now. And quality of life and patient preference must be considered because they are the castration sensitive patients. Before treatments are selected and administered to this patient, administered to these patients. So this is the new guidelines about the chemotherapy along with the hormonal therapy in castration sensitive or hormone sensitive prostate cancer patients. Next slide, please. Thank you so much.
With the permission of chairperson, can I ask a question?
Yes, sir.
Yes. So I couldn't understand this triplet therapy. Is the combination upfront of the dosi with the abiraterone, or it is the sequential is preferred that you give first 6 cycles of the dosi followed by abiraterone in continuity?
Sir, it is the mainly the docetaxel with the ADT and then the abiraterone, sir, triplet therapy.
So it's a sequential treatment.
Sir, in the trial, it is so that there are the concurrent treatment also with the abiraterone.
Can you go back to the slide, Sudhir?
Yes, sir.
I think it is concurrent. Can you show the slide? Because
yes, sir. In the trial, it is. Kindly go back for the sir. I am not control. Kindly go back for the slide.
Can someone go back to the slides? Suruchi, can you go back to the slides?
Go back, sir. 3 to 4 slide prior. Kindly go back. Kindly go back. One more, 2 more. One more. One more. One more. One more. One more, which is the Dorolata medicine. One more. One more slide. One more. One more slide. One more slide.
Yeah.
This is the sir abiraterone, 100 mg per day plus prednisolone, or this is concomitant to docetaxel. And with the radiotherapy, with the standard of care, this is the docetaxel with the prednisolone. And second arm is abiraterone plus isocic. Next slide, please. Next slide. Next slide. Next slide. Next slide. Next slide. And this is also docetaxel 75 mg plus darolutamide. They are both are the concurrent therapy for the triplet therapy with the ADT.
Right. So all the drugs are given together from virtually day
Yes,
one.
sir. Yes, sir. Only with the placebo is the second arm.
And it's a 28-day cycle.
Yes, sir.
Okay.
So,
not
Naresh, if I
21
can
days.
add
It is the
that,
phase 3 trial, sir. It is newly coming in the 2022 only, sir.
actually, the triple drug is in the peace trial. We have ADT plus the docetaxel plus the SOC, which is there. Along with that, radiation can be given or cannot be given. They didn't add radiation as a confounding agent because it was found that radiation, whether given or not given, it was not causing a bias in the final outcome. So
Yes, sir.
triplet therapy was all the three drugs which were combined.
Correct.
Compare it with the doublet therapy, there was a increment of about 10 months as far as the survival was concerned, whether it was abiraterone or enzalutamide in the doublet versus the triplet.
Yes,
Then
sir.
you
And
require very fit patients whenever you give the triplet therapy.
yes, sir. Because it is a hormone sensitive for prostate cancer, so they are the de novo. They are the general condition is good, and they are we can easily use in this data for the patients.
Sir, only thing is enzalutamide probably should not be used. Maybe what we have to extrapolate from the data, we have Arachis and Enzamate. Although Enzamate in some on day one high burden disease that might have shown, but sir, for all practical purposes, if we have to give a triple drug, it should either be a abiraterone or darolutamide.
Yes, sir. Yes, sir. Next slide, please. Next.
Again, I'll add here, Bharat.
Next slide, please.
There was a post-hoc analysis in which it was found that when you add enzalutamide to docetaxel, it was counterproductive.
Okay, sir.
Yeah, that is exactly what.
Next slide, please.
And that is why abiraterone was being used.
Next slide, please.
Right. So I think the final thing which I'd like to add, which he showed in one of his slides, was because the role of drugs like zoledronic acid or denosumab is not established in patients with HSPC.
Yes,
but I
sir.
think, can you go to the next few slides? When you have to choose between the...
Yes, sir. Kindly forwards.
Yeah. One more slide, please. Next.
One more.
Next.
One more. One more.
Next.
One more. One more.
All right.
Yes, sir. Yes,
so
sir.
I think this is where it reads denosumab or zoledronic acid, but then this is given virtually, at 6 months or 1 year interval for patients to prevent osteoporosis or the risk of fracture.
Yes, sir.
So I think this remains the same. So we should not be using these bone modifying agents on a monthly basis,
Yes, sir.
as is done in patients with CRPC.
Yes,
So I
sir.
think that is another important issue which we should take home.
Yes, sir. It is only in the STAMPEDE trial. It is also established that this zoledronic or donazumab or alendronate is not used in the CSPC. First thing is in the STAMPEDE. Then there is the now it is in 2022. There is the only osteoporosis changes are there. Then we can use. And sir, in the guideline there are the only two are the docetaxel plus abiraterone and now the darolutamide and some data of enzalutamide also, sir. If the chemotherapy is preferred for the patient.
Right. So I think the current NCCN guidelines for, I would say, in practical situation, if you have a relatively young, fit person with high volume disease, one can consider using a triplet, which is, something like either, injection of LHRH agonist or antagonist along with abiraterone and docetaxel. So docetaxel can be given for about 6 cycles, 6 to 9 cycles, and then abiraterone should continue.
And yes, sir, and new data with the darolutamide in the 2022 GUCS, sir.
Yeah, so darolutamide data is, I think, coming up very strong.
Yes,
so
sir.
I'm sure in the next few months, you will get that information, and maybe that gets included in the NCCN guidelines as well.
Yes, sir. Thank you so much, sir.
Right. So I think with this, important paper, we can move on to the next one, which is going to be by the chief organizer, Dr. Naresh Somani, and he's going to talk about this other niche indication in prostate cancer, where we are wanting to treat patients with M0 prostate cancer. That is the role of darolutamide, and Bayer is sponsoring this particular talk. So Naresh, over to you, please.
Yes, sir. Thank you. And I would like to share the screen from my end. And in continuity to what Dr. Sudhir presented, docetaxel, abiraterone, and darolutamide in a given situation. So I will be talking a little about this
Sir,
molecule.
sorry to interrupt. Just make it full screen, sir.
Yeah. Yes. Is it full screen now? So I
Yes,
will be
sir.
talking about this molecule in a given situation, that is the non-metastatic prostate cancer. As we understand that majority of the patients, they have the localized disease. May not be true in the Indian scenario, but yes, it is there. And these patients ultimately become the metastatic disease. They ultimately become from the hormone sensitive to the castration resistant disease and so on. Once there is a castration resistant metastatic disease, the downhill course becomes faster and the survival doesn't remain so good. And that depends on so many factors, including the volume of the disease, the visceral involvement, androgen PSA doubling time, and so on, and the other factors. So HSPC leading to the CRPC while the patient is on the this particular androgen deprivation therapy is something very, very interesting to us, and we need to most of the time understand it, that how it is becoming the resistant. So the patient with the non-metastatic CRPC can have the rising PSA level, but when they remain asymptomatic from their cancer, we usually call it as the non-metastatic CRPC. That means PSA is there, it's a rising, and radiologically, clinically, patient remains asymptomatic. So that's the situation, and that remains for a long period of the time, finally leading to the metastatic disease and ultimately becoming the symptomatic, castration resistant, and so on. And finally, the patient, most of the time, they succumb to their illness or the complication. So these metastases are associated with a decreased survival and quality of life and the increased healthcare cost. So it remains a concern not only for the patient or the caregiver, but as well as for the healthcare provider also. So the key therapeutic goals in NM-CRPC are to prolong the survival without disrupting the patient's daily living or the quality of their life. So there are the three things, that is the extending the survival or the overall survival of the patient, quality of the life parameters, as well as the PSA related anxiety, both in the mind of the physician as well as in the mind of the patient also. So the M1 disease on the PSMA PET, there's a new thing which is coming and bothering us, that how to deal these patients who are probably the negative on the conventional imaging versus PSMA PET becoming the positive. The volume of the disease remains so the more and more the thought process are that these patients should not be deprived of the non-metastatic prostate cancer scenario. So the present guidelines in the systemic therapy for the M0 CRPC is that you do the imaging, continue the androgen deprivation therapy to maintain the castrate serum level of the testosterone that is considered as the less than 50 nanogram per deciliter. And depending on the PSA doubling time, more than 10 months versus less than 10 months, you try to choose or dissect your patients accordingly. So patients who are the slow progression, like more than 10 months, PSA doubling time, you can monitor them, or you can consider other secondary hormone therapy versus patient less than 6 months. So the present preferred regimes are the apalutamide, darolutamide, enzalutamide. Apalutamide we will not be discussing here because presently this drug is not available with us directly in India, and there can be the other recommended regimes like the other secondary hormone therapy also. So I will be basically talking about the Aramis trial design, which is a global randomized phase 3 trial investigating the safety and efficacy of the darolutamide in non-metastatic CRPC. The trial design remains the simple. The patients are with the PSA doubling time less than 10 months. Stratification was done less than 6 months versus more than 6 months, but less than 10 months, and use of the osteoclastic target therapy. And these patients randomized 2:1, that is the ADT plus Daro 600 BD versus ADT with placebo. The primary endpoint of these trials, all these similar trials, remain the metastasis-free survival, and lot of other secondary endpoints and the exploratory analysis point remains there. So coming to the darolutamide, which is a non-steroidal androgen receptor antagonist with the high binding affinity and selectivity for the receptor. So that's a very important, and there's a little bit differentiating this agent from the other two drugs, that is the apalutamide and the enzalutamide. The other thing is that it has probably the low blood-brain barrier penetration compared to the other competing molecules from the similar class, that is the enza and the apalutamide. And here we can show that it has a remarkably low CNS penetration or through the blood-brain barrier. So this makes this drug that it doesn't have the much impact on the cerebral blood flow, and probably the making it more safer, because we also understand that we don't want much activity of these drugs in the CNS, because CNS is probably not the first or second time the metastatic site for the prostate cancer. It may happen once in a while also. So we have the three trials, three molecules, that is the Spartan, Prosper, and the Aramis, based on the darolutamide, apalutamide, and the enzalutamide. The primary endpoint of these all trials, which are having almost similar designs as far as the primary endpoint is concerned, and we have the three molecules from the same class. So the overview of these three trials, phase 3 trial, is here. Large number of the patients are there. Primary endpoint remains the same. Additional endpoints also remain more and more similar, and the eligibility criteria also remains more and less similar out of these three trials. But if we look at the primary analysis, the metastasis-free survival contrast to the placebo is the 40 months versus again the 40 months versus less with the enzalutamide. And as far as the final analysis of the data is concerned, if you look at the hazard ratio, it is a 0.69, probably the most in favor of the darolutamide compared to the EPA or the enzalutamide. That is the 31% chance of the risk of the reduction in this particular molecule. So subsequent life-prolonging therapies in patients who discontinue study treatment. That's the new point, because we know that a lot of drugs are now available, like not only the molecules of the androgen receptors inhibitors, we have the abiraterone estate also, and we have the chemotherapy also, and that also the subsequent line of the chemotherapy also. And in this particular scenario, non-metastatic castration-resistant patient who remain virtually asymptomatic, Sipuleucel T may be the another choice for the select group of the patient. So the secondary endpoints in the Aramis, Spartan, and Prosper also are very, very important to understand, and probably to select the drugs in the given scenario. So the summary of the treatment emergent adverse events, if we look at contrast to the placebo, all of them three are doing better. But if we look at the cross-trial comparison, which may not be the right way, but yes, here we can see that in the Aramis trial, the darolutamide contrast to the placebo or across the various other molecules, it looks numerically better in favor of the Aramis trial or darolutamide molecule. So the permanent discontinuation due to the adverse event is a measure of the treatment tolerability. So that's the new way to analyze the treatment tolerability. And here again, if we look contrast to the placebo, we see DARA versus placebo remains the same. Contrast to the EPA, where there's a huge difference, contrast to the placebo. And similarly, in the enzalutamide trial also, there is a Prosper. Contrast to the placebo, there is a huge difference of the permanent discontinuation. So what I would like to conclude as far as the efficacy, safety, and the quality of life parameters are concerned, the darolutamide significantly reduced the risk of the death by 31%. In the patient with a non-metastatic CRPC, that is the hazard ratio 0.69, it significantly improved the clinically meaningful endpoints, including delayed the pain progression by 15 months and reducing the risk of the initiation of the cytotoxic chemotherapy. And DARA demonstrated a median metastasis-free survival of the 40 months. That is more than double the median MFS with the placebo, seen with the placebo. And this was observed regardless of the PSA doubling time at the baseline, whether it was less than 6 months or between 6 to 10 months. So safety, again, probably it is in favor of this particular molecule than the enza or the apalutamide, but that is just across the cross-trial comparison may always not be the right way. And because it is being the non-metastatic disease, so the quality of life parameters are of the great concern with this particular molecule. So with this, I would like to thanks once again from my side for joining this important webinar. Happy festive season. Thank you.
Thank you very much, Dr. Naresh, for bringing this update on darolutamide. I think you made that point very clear that these patients are having no symptoms whatsoever. So whatever intervention we do should not in any case jeopardize their quality of life. And that is I think the best thing about darolutamide, that the discontinuation rates and the toxicity is sort of minimal, and therefore patients are able to take the drug for a longer period of time because I mean, there should be no cognitive dysfunctions or CNS toxicity or some of these drugs that are related with hyperlipidemias and so on. So I think the most important issue with such interventions is, I mean, of course, they have to be effective, which has been shown, but I think the safety is of paramount concern, and which I think darolutamide has shown in this particular trial. So I think if there is no more question on this, I think the only issue to my mind is most of these patients are going to be treated either by urologists or with the radiation people, because these are patients who have been offered curative treatment, either radical surgery or radiation. So they are in close follow-up with those physicians. So we generally come into play when there is, a metastatic disease. So I think that is an issue which we will face in our day-to-day practice. So any comments, Naresh?
Yeah, I do agree, sir. And rather, I realized now that rather than focusing more on the medical oncology for this particular aspect, we all should have the joint efforts to make the urologist sensitized that how the non-metastatic disease should be tackled.
Right. So I think this becomes a multidisciplinary care where the patients are going to be with the radiation oncologists or the surgeons mainly. So they also need to be engaged in the discussions to institute this particular agent when there is no metastasis and patient has rising, PSA, and the patient is on ADT with the control in the testosterone levels. So I think with this, we move on to the last session in or lecture in this session, and that is by none other than Dr. Prasad Narayan from I think Bengaluru, and he is going to be talking about ESMO updates on the management of gastric cancer, and there again we are seeing a lot of new drugs competing in the first line space. So let's see what Dr. Prasad is going to tell us.
Good evening. Shyam sir, am I audible, sir?
Yes, Prasad, you are audible and visible.
Thanks for the introduction, sir. Thanks for this opportunity. I mean, since this COVID situation started, I have been seeing, I've been a part of many webinars with Shyam sir. And I should appreciate that the flowers near your, this is the corner you choose every time for your webinar, and they are always fresh, sir. I appreciate that. So we will go ahead with this ESMO guidelines update on gastric cancer. And this is an Eli Lilly sponsored session. I have been contracted by Eli Lilly for this. This is my disclaimer. So we will go, this will take maybe 10 minutes time. So this is about updation of the guidelines from 2016, 19 and presently, which is interesting how medical oncology treatment in advances and how we, one treatment which was the standard of care sometime becomes a non-acceptable standard of care with time. That is how science advances. So if you take the 2016 Annals of Oncology update, the ESMO guidelines management, the first line treatment doublet or triplet was accepted standard of care with the DCF and FLOT regime, which we all used for a lot of patients in first line. And then the second line there also was the standard of care was to give ramucirumab with paclitaxel based on the studies which we all know about, either single agent ramucirumab in unfit patients and in combination with paclitaxel. Similar efficacy was seen for single agent if you are only choosing chemotherapy, paclitaxel and irinotecan. Those were the second line treatment options. And trastuzumab, the data of trastuzumab in HER2 positive was just coming, and that was also approved as a personalized medicine and targeted therapy. Then when you see, so if you see the publication in 2016, this was the flow chart. The palliative chemotherapy, either giving a combination of a FLOT or a DCF kind of protocol, or in HER2 positive breast cancer, giving the CF with trastuzumab. And second line therapy was the paclitaxel ramucirumab, or in MSI high patients, the pembrolizumab. So then in this is again a continuation of the same in Lancet 2020, when still we didn't have much updation in terms of the first line therapy. So what has happened, or the new publication which came in 2022, few things we all know about the trials which actually came in first line metastatic gastric cancer with immunotherapy coming in. And now we are looking at more options for patients with first line in first line therapy. So the HER2 status, we all do that now. It is almost a standard of care to check the HER2 status in all patients with gastric cancer. And now with the present data of of the pembrolizumab as well as nivolumab data, the PD-L1 CPS score should be evaluated in patients with metastatic gastric cancer to tailor first line therapy. This is based on the randomized trials of nivolumab and pembrolizumab in this group of patients. So first line chemotherapy, if you the recommended therapy now is a doublet chemotherapy. Platinum with fluoropyrimidine is recommended. And specifically, if you see what I said in the beginning was that the standard of care becomes changed. So due to higher level of toxicity and uncertain survival benefit, a first-line taxane-based triplet therapy is no longer recommended as a standard approach. That is the present guideline clearly says that a triplet chemotherapy is not to be considered in first-line metastatic gastric cancer. And trastuzumab chemotherapy is recommended in patients with HER2 positive cancer. And the other two drugs, the nivolumab chemotherapy. This is based on the randomized trial, which proved that in patients who have PD-L1 CPS score more than 5 with untreated gastric, esophagogastric junction and esophageal cancer, there is an improvement in survival by adding nivolumab to chemotherapy. Similarly, for advanced gastric cancer of esophagus and esophagogastric cancer patients expressing PD-L1 CPS score more than 10%, pembrolizumab is also approved. So the new flow chart doesn't have a triplet chemotherapy as an option, or it is considered as it's a wrong treatment to choose if you want to give a triplet chemotherapy in the present scenario. Test the patient for HER2/neu. Add a triplet combination, can be either an immunotherapy combination or a targeted therapy with HER2/neu in patients who qualify for that. So in HER2 positive patients, the addition of trastuzumab with high recommendation, and in PD-L1 CPS score more than 5 patients, the addition of nivolumab. There is also a mention of radical resection in highly selected cases. These will be patients maybe who present with obstruction or bleeding, and mostly we don't have patients with advanced gastric cancer who go for radical resection. So what is the scene in the second line? This is something we all know, that most of the patients with metastatic gastric cancer will progress. And with the present regimes, I think we can say that we can get a first line patient getting a PFS of something close to 9 to 12 months with the present first line therapy options that we have. But most of these patients progress. And with the data of post-progression immunotherapy, we don't have strong data. But the present recommendation with what we have is that still the second line option is ramucirumab paclitaxel as a standard of care. and ramucirumab monotherapy in those patients who cannot take chemotherapy because of some reason. If ramucirumab is not available or the patient cannot afford, which is the scenario in our country, irinotecan, paclitaxel, docetaxel, or even FOLFIRI, if the patient is fit, are recommended therapies. We all use these chemotherapy options. So keeping the taxane for the second line, regardless of whether the patient is going for ramucirumab, is a good option because that helps us to prolong the PFS of the patients and like that the overall survival as well. And MSI and MMR status should be assessed for patients with advanced metastatic gastric cancer to tailor treatment accordingly. So second line therapy options, if there is no contraindication for chemotherapy or anti-angiogenic therapy, the treatment recommendation is ramucirumab and paclitaxel. If there is contraindication for chemotherapy, then ramucirumab monotherapy is approved therapy and is recommended. If there is a contraindication for anti-angiogenic therapy, then a single agent taxane or irinotecan, most of us use on a weekly basis for many patients, which is accepted standard of care. And if the patient has an MSI high, pembrolizumab monotherapy. So this is the recommendation in second line patients. And with the data on trifluridine which we have some access now, we have this also coming in for patients previously treated with 2 lines of therapy. So we have a third line approved option, which is trifluridine now. Alternative therapy could be a patient who has not received a taxane or irinotecan. It can be considered as an alternative therapy. So in third line, the approved treatment is chemotherapy. This will definitely change when more patients will get first line immunotherapy, chemotherapy combination. I'm sure that we will all have patients very soon who will be progressing on these protocols, and we will be waiting for the long-term data to see what is the best second line, third line options in patients who receive immunotherapy in their first line. So as per the present guidelines, the third line therapy option is chemotherapy, oral therapy if it is possible, or IV therapy is preferred with taxane or irinotecan, and trifluridine is also approved in this scenario. So this is the last slide, I think. In summary, HER2 status and PD-L1 CPS, it has changed in the last decade. I would say that the treatment of first line metastatic gastric cancer has changed because of these 2 data which we have. All the patients should be evaluated in metastatic gastric cancer to tailor the first line therapy in combination with chemotherapy. MSI should be assessed for second line therapy. So most of us, we do it in the first line to have the data with us. Doublet chemotherapy is first line standard of care, and all the guidelines now clearly mention that a triple chemotherapy like FLOT or DCF is not recommended in first line. Immunotherapy plus chemotherapy is definitely the standard of care for first line PD-L1 positive patients. FLOT is no longer recommended as a standard approach. We still use in some scenarios, but it is not recommended as a standard approach due to specific reason. And ramucirumab paclitaxel is still holding the second line recommended treatment option when the patient can tolerate both chemotherapy and anti-angiogenic therapy. When ramucirumab is not available or not affordable, or there are other contraindications for anti-angiogenic therapy, a single agent chemotherapy with paclitaxel, docetaxel, or irinotecan, or a combination of chemotherapy is recommended. That's all from my side. Thanks a lot for patient care.
Thank you, Dr. Prasad. Just to seek a clarification. So I think these slides and recommendations are meant for patients with metastatic or advanced gastric cancer.
Yes, sir.
So FLOT is still good for patients who have resectable gastric cancer in the neoadjuvant setting.
Yes, sir. So resectable gastric cancer is a standard of care because we can afford to have we'll agree to the toxicity in those patients where we are going for a curative intent therapy.
Right.
In continuity to this, can I ask a question, Dr. Shyam sir?
Yeah, Naresh.
So we assess that the patient is locally advanced. So we give the FLOT and then we try to operate, and patient remains inoperable or the peritoneal mets are there. So in a responding patient, tolerating patient, in this scenario, will you continue FLOT or you will try to change to the lesser toxic regime like the FOLFOX or CAPOX?
So you mean to say the patient had a response in the scan. We went in for resection and found it is metastatic disease.
Yeah.
In such a, if this is a scenario, I would continue the treatment which the patient responded to, sir. I will not now go down on this patient.
That's a common scenario. Yeah. Yes, sir.
Yeah, if the patient is tolerating, I mean, why to change the therapy? If the patient is not, I mean, we understand that this patient is having incurable illness because of the peritoneal metastasis, so which were not seen at the time of CT scan or PET scan before starting FLOT, which were only visible on the operation table. So that does change the stage to an advanced disease.
Sir, there are the two questions in the chat box. One question is similar, almost similar by Dr. Vineet Talwar and me. Dr. Prasad, would you like to answer?
So Dr. Prasad is there. So Prasad, do you use pembrolizumab in first line for an MSI high?
Sir, I'm still getting used to the immunotherapy in first line. Couple of patients only nivolumab I have not used pembro first line actually.
No. If the patient is MSI high in the first line,
MSI high.
Yes, you're talking about MSI high. That is the question of Dr. Naresh.
I very recently had a patient. PD-L1 is not supporting the use of the IO, whether it's the pembro or whether it's the nivo. But the patient's this MMR turned out to be the deficient with the two markers, PMS2 and something like that. So I try to continue with the because of the FOLFOX, I try to continue with the nivo being the 2 weekly schedule. But if I use the capox, then I would like to add the pembro.
First line single agent pembrolizumab in metastatic gastric cancer. I don't know how many of us have actually given.
No, not single agent, along with the chemo.
No, to answer that question in chat box actually, yes. Along with chemo, fine, because we all want that response actually.
So single agent IO based on the MSI is there in the other malignancies.
Yes. Yes, sir. Agreed.
No, Prasad also showed in the second line that if MSI is high, then pembro can be used as a single agent.
Right.
So the question is only in the first line whether you can do it alone or in combination with a FOLFOX-like regimen.
Second line MSI high based IO is there. I think it's a blanket approach.
Right.
Anywhere if the
Vineet, your call.
So the first line, even if the MSI is high, I have seen it in a couple of my patients. If we gave a single agent because the general condition was not good, the behavior is not like that of what it is seen in lung. The response rates are abysmally low, and invariably after 3 or 4 months they relapse. So, as Prasad said, that if you give it in conjunction with chemo, probably that would be the best bet.
So Dr. Vineet, when based on the PD-L1, you can use it in the first line along with the chemo. Based on the MSI, why not to use with the chemo in the first line?
See, logic does not play a role. There are so many other situations which all of us can quote that in phase 2 it worked like magic, and then when it came to phase 3 it flopped miserably.
So PD-L1 positivity is a marker of the positive predictive value or a marker of the negative predictive value if the PD-L1 is negative?
See, you can chew the data whichever way you want, but at the end of the day, if you have a trial and you can prove it, probably that's what it works.
So I think the bottom line now, and I think let me just also state this for the sake of clarity, that this data holds for adenocarcinoma, whatever was presented. So it is not for esophageal squamous cell carcinoma. So GE junction adenocarcinoma or stomach adenocarcinoma, I think Prasad presented the data here for that. So I think it has become prudent now on the part of oncologists to not only do the HER2/neu testing, but also to include CPS scoring on the tissue so as to decide in the first line for using either HER2/neu inhibitors or using the IO drugs, depending upon the CPS. And I think both have a level 1 evidence as was shown in the slides. So I think the practice is evolving, many drugs becoming available. So if somebody has CPS more than 5 and HER2/neu 3+ as well, so then I think HER2/neu will take precedence over the IO drug. Prasad?
Yes, sir. Agreed. Agreed, sir.
Right. So I think we have a fair amount of consensus here today. And of course, a second line does not get altered. Whatever you use in the first line, ramucirumab with paclitaxel remains the second line treatment, irrespective of the CPS or HER2/neu, etc. So I think third
May
line.
I add something here?
Yeah.
You've given Folfox and Nivo. You have a CPS of more than 5 in first line. Patient progresses, and then fortunately or unfortunately, you check the MSI, it is high. So re-challenge of IO, single agent. Now what do you say?
Second line, it is approved.
That was your question.
Yes, second line, it's an approved standard of care. If the MSI is high in second line, we can use pembrolizumab single agent.
But Prasad, you have already exposed to one IO.
Agree, sir. But the data, I mean, as of now, we don't. That's what I said, that when we have more patients, more prolonged data on the patients who progressed on Nivo plus chemo combination, whether they will respond to a single agent immunotherapy is questionable, but it's an approved therapy.
Right.
Yeah, so it's I know it's tough, Vineet. You're putting everyone into a corner because there may not be, I mean, this can be applicable to other malignancies also, where in first line Nivo or Atezo are approved, and then you find the MSI to be high. So should this patient be re-challenged with a drug like Pembro, or should you give, for example, in stomach cancer, still hold on to ramucirumab in the second line by a few months before you re-challenge with pembrolizumab? So, those will be important discussion points. But I think we need to use all the agents in metastatic disease to sort of in a sequential fashion to give the best to our patients.
Probably in the third line we can place it.
Right. So I mean, I think options are definitely open. You may not have the answers right now ready, but I think again, for patients who have been exposed to an IO before, a doublet of IO is also shown to be effective in so many trials. For example, in RCC, when Pembro and Exi fails, a doublet has given some positive data only in the phase 2 settings. So I think here you are reversing the drug scenario, Pembro followed by Nivo before. So so I think these are sort of issues which will perhaps remain for a while until we have more data in this direction.
Thank you, sir.
Thank you, sir.
Right. So I think with this, we can close this session. Thanks to all the speakers for giving excellent talks and having an interactive discussion. So it's over to Dr. Naresh for and his team to continue.
Do we have the Dr. T.P. Sahu with us to make the final concluding remarks of the day 1 of this meeting? Dr. Sahu. So if Dr. TP is not here, I think Dr. Shyam Agarwal has done a nice concluding in the discussion. Otherwise, in a lighter vein, in the last, I would like to say, as far as these gastric guidelines are concerned, I will be treating the patient first line with the Folfox plus minus IO. Then Dr. Shyam will be treating the patient with the Cyramza with the Taxan. And finally, the Vinith will be treating the patient with the pembrolizumab. This is how the patient journey moves from Jaipur to Delhi, or from the 2-tier city to the 3-tier city, or from a treating center to the referral center. So with this,
so Naresh Somani sir, I would like to request to select the best question of the day.
So I have requested, Dr. Shyam has not gone into that.
Yeah.
Dr. Shyam has seen that or not? So there were the 3 questions in my mind which I could click. So I would request Dr. Shyam sir to make the choice out there. Let me present these questions to Dr. Shyam sir. One question is from Dr. Anu Raj Purohit. If the HAR is a dynamic, so repeat biopsy is advised prior to the TDXT or dextricam therapy. That is the one question she is asking. And two questions are from the delegates from the Dr. Mukandar Sheikh. Is this possible that the patient ERPR negative and HAR2 positive? So I don't know in what context he has asked this question. And one is from Dr. Lepakshi. Is the HAR new testing in fresh sample change in the concurrence rate? So there's another question. I don't know in what context CHR. So Dr. Shyam Agarwal, sir, what do you think that which question?
Can you repeat the first question from Dr. Anu Raj Purohit? I think that seems pretty okay. Yeah.
So that's the prize winning from the 2 days. And who will be actually answering this? Should we repeat the biopsy to make it like 0 or 1 or 2?
So regarding the repeat biopsy in breast cancers, I mean, what they are saying is that when patient develops metastatic disease, so, you know, one biopsy is always in order or sort of mandatory in the course of illness to look at the evolution of the ERPR and HER2 new status. But let me also add this, as the practice is evolving in the Western countries, a lot of liquid biopsies are being performed on a sequential basis. Once the patients, they stop responding to one treatment, then they have to go on to the next. So I think we are still not there in our country because the liquid biopsies, I think the expertise is developing. I've been having discussions with labs like MedGenome who are really doing very deep sequencing, because for liquid biopsy, in order to be validated, you really have to go 5,000x, 10,000x. So I think repeat biopsies, especially liquid biopsies, are going to be in practice as we have more and more targeted drugs also available in the future. So I think liquid biopsies and repeat biopsies are futuristic, and actually at the moment in our country being practiced, like in lung cancer and even in breast cancer.
Thank you, sir. So this prize goes to Dr. Anu Raj Purohit, and the other prize of remaining maximum time, I think that will be, we will be announcing it tomorrow based on the how they screen the data and they do it. I think the back team will be doing it. And with this, I thank all of you, and I hope that tomorrow you again will be joining. And once again, happy festive season and coming Deepavali to all of you. Good night.
Yeah. So happy Navratri.
Happy Navratri. Good night. Good night, everyone. Thank you for joining. It was a brilliant discussion. Thank you, everyone.